couple of our people might still be filtering in. May I have your attention so we could start, please? Thank you very much. To the members, you'll see that this is a paperless committee but unfortunately there will be, there will be lots of numbers today, and it's kind of easier to see on paper than on your screen, and I appreciate Elizabeth for printing these out. There will be a slight amendment to the agenda. At 8:45, KDHE will give us time at the end of the day for an hour or so, or 10 minutes to present for answers and questions. So the presentation by KLRD will start at 10 a.m. They'll just walk you through it as we go along. We do have until 12:30 today. We do have a full day tomorrow. We're going to begin by a presentation from KLRD, an overview of Medicaid funding. Thank you.
Good morning. I'm Megan Leopold with KLRD. It's early on a Monday, but I think I have a topic here that's really going to keep you on the edge of your seat, Medicaid funding. What I'm going to provide is just a very high-level overview of Medicaid funding. You're going to be hearing a lot of details from the actuaries and KDHE, and I'm hoping that this will just give you some context into which you can fit the information that they provide. So to start off, oh, there it goes. All right. Medicaid in the state budget is a coordination between KDHE and KDODS. So you'll see pieces of it in both of those budgets. In KDHE, they cover the medical pieces of Medicaid. So, whoops, sorry. Those are doctor's visits, hospital visits, those type of provider visits. They also cover the administration. So those are the databases that keep track of all of the claims from providers, all of the different payments that are going out. They administer the state plan. They also oversee the MCO contracts, and then also the actuarial services. For KDODS, their focus is really on behavioral health, so the CCBHCs, the nursing facilities, and then also the Medicaid waiver programs. When you hear about Medicaid expenditures, one thing that you often hear about is capitation. These are the state payments, or the payments that the state makes to the MCOs. So the capitation payments are often referred to as the per member per month. So KDHE pays the MCOs, these are the managed care organizations, of which there are 3. They pay a payment based on the number of people or individuals that are enrolled in each of the various eligibility categories each month. I'm going to go into this a little bit in more detail further down, but I just wanted to give you that information. This is what capitation payments are when you hear that term. So while KDHE, or the state, pays the MCOs based on member, so their payments are made based on the number of members that are enrolled in each eligibility category. When you hear about provider reimbursements, or the payments from the MCOs to providers, those are made based on a service. So there's a slightly different way in which the money goes from each of the entities. So the MCOs reimburse individual providers and organizations based on each of the services they provide. So that could be a child going in for a well visit or a broken arm to maternity. There are a few exceptions to that. CCBHCs, nursing facilities, and FQHCs, federally qualified healthcare centers, they're reimbursed on a prospective payment system, or PPS. and that is based on the person served. But the vast majority of payments that filter from the MCOs to out into claims that are input by providers are based on the services that are provided. Each MCO develops their own provider reimbursement rates. So when you hear about rates and you hear the legislature, when you all decide to change a rate or raise a rate, what you're raising is the minimum rate that can be paid for that service. So when you talk about a rate for an IDD provider, the MCOs have to pay at least the rate that the legislature or the state has decided upon. They can pay more if they choose, but they cannot pay less. So going back to the capitation payments. The capitation payments are the main driver of Medicaid costs. So this is the vast majority of anything that the state pays out for Medicaid is based on these capitation payments. So the payments are based, like I said, on the number of people that are estimated to need a certain type of service, and that's based on the reason that they're eligible. So services, like I said, can range from a child's well check to a heart transplant. So you have a real variety of services, and different categories of individuals are going to need more or less services. And because the state is paying the MCOs based on the type of services that they will need, they're broken down into rate cells. These rate cells help us to estimate costs and pay the MCOs costs that are closer to what they will actually accrue, because Medicaid covers such a wide range of individuals and individuals with different types of needs. So the rate cells reflect the group of people that are categorized based on their anticipated interactions with the system. So if someone is eligible through a waiver, they're going to have very different anticipated level of services than a child that's eligible due to income. There are approximately 34 different rate cells that are used in creating the estimates. Some examples are the waivers. There's poverty level eligible children, children receiving long-term care. So these are children that are eligible because they have very intense needs that require long-term care. Pregnant women, medically needy, aged, blind, and disabled, and long-term care recipients. So each of these groups has a unique rate that they are paid, that the MCO payments are based upon. So when we talk about caseloads, and you'll hear our caseload estimates later on in this committee later today, one of the main things that we do is we look at each of those rate cells. And really what we're looking at is that population in the rate cell that population is assigned. And so we're looking at the number of people that are going to be eligible or that we anticipate will be eligible in each of those rate cells. And then the number of people is multiplied by the rate that rate cell is given. And then that gives you your overall capitation rate. So when we do caseloads, what we're doing is forecasting into the future the populations for those various rate cells that we anticipate. And that is based on previous data. It's based on policy changes, and I'll go more into that a little bit later. The MCO rates, and again, what the state assigns as the rate are the minimum rates that the MCOs can pay. These are regulated heavily by federal statute. Because Medicaid is a joint commitment between the state and the federal government has very high oversight into how these rates can be established because they're paying 60% generally of the rates. So in order to avoid overpayment, the rates must avoid overpayment. So they are statutorily required to avoid payment for unnecessary utilization, but they also must be sufficient to enlist the number of providers needed. So there's a balance between not paying too much, not having the rates be over what they need to be, but also they need to be high enough because the state is statutorily required to have a provider network that can cover everyone that's on Medicaid. So there's that balance. They need to be high enough to maintain the provider network, but they can't be above a certain limit. And then capitation to risk-based managed care plans must be made on an actuarially sound basis. You're going to hear a lot more about this. It's very complex, but the actuaries go to great lengths to make sure that these rates are that meet the requirements of these federal regulations. And then the rates must be approved by CMS, which is the Federal Oversight Committee. Other cost drivers that you have in the Medicaid funding that you hear a lot about, one is the FMAP. This is the Federal Medical Assistance Percentage. Like I said, Medicaid is a partnership between the federal government and the state government, and this is the ratio of payment. So the FMAP, which is reset every year, is the state or the federal match rate. So this is the percentage of Medicaid that the federal government will supplement. This applies to Medicaid, adoption assistance, and also foster care. And like I said, it fluctuates each year based on the federal fiscal year. And it's calculated on a 3-year average per capita personal income. So it changes based for each state. Each state has a different FMAP, and it's based on that per capita income. And you can see on this slide, the FMAP for 2025 was 65.75%. The FMAP for 2026 was 64.69. So it's a very incremental change from year to year for the most part, but because Medicaid is a $6 billion program, it does create quite a significant difference. Other cost drivers that we see in the Medicaid program are changes in federal policy. So one example of this is the disproportionate share for hospital program. This is a program that has been, from year to year, had some cuts put into place. There's also a health insurance provider's fee that has been repealed, but these are examples of programs that the federal government has that impact the state payments that change from time to time. And these are also things that we take into consideration when we're creating the caseload estimates. There are also changes in state policy or programs. So one example of that is the provider assessment. This is in Senate Bill 125. There was provision to raise the provider assessment from 3% to 6%. This will have an impact on the federal funds that are coming into the state when that goes into effect. And also the rate increases. So anytime the legislature makes changes to the rates, then we're going to see a fluctuation in that per member per month that the MCOs are receiving. And then my last 2 slides are just a picture of the historical expenditures and then also the historical membership. So for the expenditures, you can see that the top line, the top segment there is the SGF, and the bottom section makes up the federal share of the Medicaid expenditures. And then on the membership, you can see there that between 2020 and 2023, we had a significant increase, and that was because of the COVID regulations. The federal regulations that gave us an enhanced FMAP also required Medicaid to continue to keep everyone on Medicaid as long as they were originally qualified for it, and no one was allowed to be removed from Medicaid for that time period. So you saw it go up, and then as that ended, you see the population going back down. And with that, I'm happy to stand for any questions.
Questions, committee? While they're thinking, I have a few for you. So when a new beneficiary from Medicaid enrolls, how is it determined which carrier that is selected for them to go to?
The individual will have an option to choose the MCO. And if they do not choose on their own, then they'll be assigned.
And then how is that determined?
How I believe, and the agency can speak more to this, but I believe they attempt to keep the enrollment between the 3 MCOs relatively stable or relatively the same between each one. And so I think they will assign based on if one MCO has fewer beneficiaries than the others.
Okay. And then the next question I have is, how is it determined that behavioral health is separated from the medical services? Is that state statute, or is that just something that's determined by the department?
I believe that's really just the way that the state, how Kansas has organized their system and their agencies. KDADS is aging and disability, and so the mental health piece of it falls more into their purview than KDHE, which really just focuses on the medical. And I believe that's a state decision.
And then when you were talking about the capitation, and I know you can't answer this, but I would like for somebody to answer. I've never seen a breakdown of capitation. Like we have X number, Blue Cross has X number of children based on poverty, and they have X number based on this or that, to kind of see how that capitation breaks down. Of course, we wouldn't want names or any identifying information. Mm-hmm. Next, who determines the rate cells? I assume that's the actuarial department.
Who determines the rate cells?
The rate cell as to if a person has X, we expect they'll use X number of services, therefore the capitation amount will be X for that rate cell.
Like how they're divided out or how they're categorized. That's a good question. I don't know. They've never changed since I've been here. I don't know if there is some federal regulation around that or if that's an actuarial decision, but they can, I'm sure,
Good.
speak to that.
I'm asking you these questions, so when they come up, they'll be ready. I see them all giving me a thumbs up. Also, there was a slide that you were talking about as far as provider compensation. And it's on slide 10, and you say, avoid payment for unnecessary utilization. That's very different than overpaying, right? So unnecessary utilization is making sure that you're not sending people to providers or that providers are not abusing the system by maybe seeing someone too often or for unnecessary purposes. And that's very different than overpaying, right?
Right, and I believe that also gets to when you have rate cells, one rate cell, for instance, children aren't going to need open heart surgery. And so you take those things into consideration. And again, this is something the actuaries can speak to, but I believe that is getting to the idea that the rate cells are put into place so that when the rates are determined, they're not funding procedures that wouldn't be necessarily used by that population.
Thank you. And then could you explain to the folks that are listening, what are DISH funds or disproportionate share funds?
Yes, DISH funds are funds that go to hospitals based on the number of Medicaid and uncompensated care clients.
And uncompensated care would be people who come in and then can't pay.
Correct.
And so how are they reimbursed for that?
It is a funding stream that is allocated out to the hospitals. And as far as it's based on the number of Medicaid patients, but
We
there is more I
know
can.
when the ACA was being structured to get hospitals on board, one of the things they said was everybody will be insured, so you won't need disproportionate share funds anymore to pay for those who are coming in and you're not getting compensated. So those would be cut. However, those have not been cut. Every year the can gets kicked down the road and hospitals are still receiving their disproportionate share funds, correct?
That is correct.
All right, thank you. And then finally, the 3% to 6% provider assessments. Could you explain that?
Yes. The provider assessments are, it's a program that takes advantage of that 60% federal match. So this is for the hospitals specifically, when the hospitals pay the state, they add an additional amount to that, and that is the provider tax. And that is based on their inpatient and outpatient income, or net income. And when the federal government, or when the state draws down the federal funds, they're able to draw down a higher rate of federal funding for that service. And then that higher rate, the difference goes back to the hospitals. So it's playing up that 40% state funding and 60% federal funding, and giving it to the federal government at a higher rate, so then that state reimbursement is higher, and that goes back to the hospitals.
It's a bit of a Ponzi scheme so that we get more federal dollars. And so therefore, the Trump administration has said we're not going to do that anymore, so they're cutting that back. So I'm not sure if this 6% is going to stick or not. We'll see. Additional questions, committee? Those are mine. Yes. Senator Petty.
Thank you, Madam Chair. So, Megan, this is a follow-up. I don't believe when ACA came about that there was ever a statement that everyone would be insured. I'm not knowing what that would be based on. People would be eligible for insurance, but that everybody would be insured. We're always going to have uncompensated care, and our hospitals, our public hospitals, have to provide for that uncompensated care.
Senator Peck.
Thank you, Madam Chairman. For some of our older members, like Representative Sutton and Representative Bryce, they'd like to have the light on here, if you don't mind turning it on. Oh, it's not working? Okay. A quick question on the historical, thank you. On the historical expenditures, it's got a graph, but it doesn't have the exact dollar amounts. I'm most interested in, of course, the state general fund dollar amount, but is there some way that we could learn what those exact dollar amounts are on the historical expenditure? That was my only question, Madam Chairman. Thank you.
Yeah, I have a table I can provide to the committee.
Representative Bueller.
Thank you, Madam Chair. And Megan, thanks for being here. So on the last slide, when it's showing historical membership, and I know the big jump that happened in 2020 was COVID related, but this is for all Medicaid populations, and we're still north of probably 470,000, whatever that number is. Does anyone know if there's been a shift in the demographics of who those populations are, or has there been a shift to a lower age or a certain recipient? So I'm kind of interested to see if there's been a change, but from 2020 to 2025, we're still higher than we were. And is there a group that we're providing services to that we previously weren't? So is there a way to get that?
Yeah, I can look into that. As far as I know, there are not any new groups. There have been some policy changes where eligibility to certain waivers has been expanded, the brain injury waiver, for instance. I believe that happened prior to COVID. But yeah, I can look into that and see.
I'm just looking to see if there's been a shift in terms of services of who we're providing services to, and if one is proportionally larger today than it was 5 years ago.
Sure.
Okay, thank you. Thank you, Madam Chair.
Senator Erickson.
Thank you, Madam Chair. Thank you, Megan, for the presentation. A couple of quick questions. I'll stick with the historical chart here that you provided. If I look at the historical membership and historical expenditures, up until 2020, the membership was pretty flat, to Representative Bueller's point. Then it went up, but it certainly, and it has come back down a little bit, it certainly hasn't doubled. But if you look at expenditures from 2015 to 2025, at least doubled and growing. Mm-hmm. So that tells me it's not because we're necessarily doubling the amount of people. So that tells me it has to be an increase in the rate. Would that be a fair assumption?
It is partially an increase in the rate, and actually later in today's committee, I will discuss some of the legislative ads. And it's largely legislative ads that have been made over the years with rate increases and things like that. So I have a table listing those out, and I'll provide that later. That should
And
answer.
just one more, if I may, Madam Chair. So on the provider reimbursements, very easy to understand that MCOs reimburse for either a service or a PPS. Why? Why two different systems? Why not just for services?
I think that's more of an actuary question, but I believe it's just because of the populations that are served in community mental health centers and CCBHCs. They're going to see a wide range of services. And so it's just, I think, in order to get a better estimate on what they'll actually need, because it's a different type of situation. But the actuaries can speak to that.
If we dig into that data a little bit more on the PPS, I would be very curious as to what rate cell, I take it that they have the same rate cell system? Do they have the same for a PPS?
I would need to look into how the CMHC funding and rates fit into the rate cells. Because it's that population, any rate cell can use those services. So I believe that that's also why that there's a different funding makeup for the reimbursement, but I'll look into that. And the actuaries might also be able to speak to that.
My final question, what if there's an individual that has both, a PPS and a service? How are they counted in the numbers?
Well, the PPS and the provider payments are two separate entities. So one individual could go to a doctor for a broken arm, and they would file a claim, the provider would file a claim, and that would be reimbursed based on that service. And then later that day, they could go to the CCBHC for a therapy session, and then that would be reimbursed based on the PPS system.
Thank you. Thank you, Madam Chair.
Representative Ruiz.
Thank you, Madam Chair. And this is more of a comment, again, with the ACA. Not all ACA plans, well, not all health plans out there meet the ACA requirements. So if you look at some folks that are under some insurance, again, that doesn't qualify, it's because they are not providing certain things that is required under the ACA qualified plans. So if they're not doing that, then that means that there are agencies and organizations, hospitals who are providing services that are not being reimbursed. So I think that's where we see what your first question, Madam Chair, about the hospitals and some of the payments that they're getting, that it's because a person might be on a health plan that is not truly qualified under the ACA.
Thank you very much, Representative Ruiz. Let me just clarify. As a health insurance agent, of course, I'm familiar with all the various plans. And because of the ACA, it's extremely rare to find a plan that does not meet all the qualifications because carriers don't write them. You might find a few short-term medical plans that are for a short duration. You also might find, for example, Farm Bureau does not fall under an insurance plan, but other than that, or you might find a very rare group plan that doesn't offer an ACA. They could be subject to a fine just depending on the number of population. I want to be clear, perhaps I wasn't. I agree with disproportionate share funds. I think that's important for hospitals to reimburse if they come in. I was just explaining those have not been cut because it was saying in here that they could potentially be, but they have not. I just wanted to clarify.
And that's, I'm glad that you clarified that and that you're on board with that. Just one more thing I want to say. Some
right
of those
ahead.
plans that don't qualify anymore, or insurance companies have pulled out. They're not offering anything. I've already spoken to two people who they've already received notice from their insurance company that they're pulling out of the ACA, so they're not going to be able to be insured anymore. So I think we're going to see more like that.
And unfortunately, with the ACA, you pretty well have to get a plan through the ACA or there isn't any other option. available to you.
Yeah, because, just cuts coming all over the place.
All right. And one last question then, and do we have anybody else? Oh, Representative Sutton.
Thank you, Madam Chair. And Megan, I think you kind of touched on this, but I just want to verify and make sure that I'm understanding it correctly. On slide 13 there, you said under the other cost drivers, changes in state policy or programs. You mentioned that that's almost always legislative. What other option would there be that would increase the cost without legislative action?
Under the state policy,
Right.
yes, that's going to be legislative.
Okay, very good. 100% of those changes in state policy or programs are legislative?
I would have to think about that before I say 100%, but it's going to be, any changes that occur are going to be included in the caseloads. And so we discuss, in that memo, we list out any changes that are made. Again, it's largely population, but any policies that change are going to be included in there too.
Will be included in the numbers. I very rarely see the digestion of what went into those numbers, however.
Into the caseload numbers?
Right, in appropriations anyway. Maybe somebody else looks at them, but in appropriations, I don't see that.
Policy changes that are not federally regulated are generally going to come up as supplements or enhancements in the agency's budget. So when we look at caseloads, generally, any of the policy changes that are in there are federally mandated, and if they were not implemented, then the state would risk losing that federal match.
Sure, I understand.
Any changes, one example is the extension of maternity care for women. That was an agency supplement, and so it was included in their budget as an enhancement for the Medicaid program.
Right, very good. Thank you. Thank you, Madam Chair.
And one last question regarding the funding. We've been hearing on social media that, oh gosh, the sky is falling and, we're going to lose all these Medicaid funds. Is it true that the federal government is cutting Medicaid?
That's a really complex question. There are many changes to the Medicaid program included in the federal legislation, and there are a lot of places that outline those very well. I can't speak to all of them, but I can provide some information on it.
So we do know, and when the department comes up, they will share that with us, but we do know that no illegal immigrants or illegal aliens will be allowed to be on the program. I don't believe we have any in Kansas, but should there be, they would be taken off. We also know that we want to make sure people are eligible for the program, that we're saving the funds for those who are eligible, but no actual cuts to FMAP or anything like that that you're aware of. Is that right?
I would rather not speak to that just because I don't have all the regulations in front of me, and there are many. So.
And you showed us what 2026 was going to be.
Correct.
Okay.
As far as I know, the FMAP, the way that it's established, is not impacted by the federal regulations at this point.
Thank you very much. Oh, I forgot Representative Carpenter.
Thank you, Madam Chair. Megan, thank you for this information. I would be remiss if I talk about this all the time, and a lot of the information she's talking about is in this Medicaid report that you can get from Megan. She can send it to you. It talks about all the capitation rates and the rate cells and what we pay per rate cell, ID and DD or kids or any of that kind of stuff. So it's a very good report to see. It gives total numbers, monthly expenditures on all that kind of stuff. So first thing I do about every 2 or 3 months is get a new one and see what's going on with this. But I will talk about a little bit about the Ponzi scheme that you mentioned with the HCAP. And I agree 100% with that, but it's legal. And we are competing with our surrounding states that use that to supplement their hospital incomes too. So I get the fact that you tax yourself, you turn it in on the state's portion, and basically the Fed pays the 60%, of the FMAP. I get that. But again, we're competing with all these surrounding states that have a 6% FMAP or a provider assessment. So our hospitals would be at a $400 million disadvantage versus our surrounding states if we didn't have that provider assessment. Just want to be clear about how that.
Thank you, Representative Carpenter, and you and I carried that bill to allow that 6%.
We did. And I have on pretty good opinion that that's going to go on because of our federal senators and congressmen got involved in that process. And we were late to the game because all the other surrounding states had already done the 6%. But I understand in the bill that it's going to continue. Our application will be approved at up to 6%. So that's good news for our local hospitals. I just found that out, I think, Tuesday or something. So anyway, thank you.
Thank you, Representative. We're going to move on. Committee, thank you so much, Megan. To the report regarding costs of providing services, and we will have Seth Adamson.
There we go, much better. Hi, my name is Seth Adamson. I'm a managing director with CBIZ. Oh, is it on? Check, check. There we go. Let me move it up a little. Kind of tall here. There we go, much better. Hi, morning, everybody. For the record, my name is Seth Adamson, managing director and actuary with CBIZ Optimus. We're the actuarial consulting firm for the Kansas Department of Health and Environment. And today we'll be going over the actuarial components of capitation rate setting. So I took a few notes on some of the questions from Megan, so I may be able to address a few of those items as well and provide some clarification. You'll see there's quite a few slides there. We'll go through the efficient version of the presentation for our time slot here today, but a lot of good detail there for you guys to review. Certainly we'll pause for questions. They may do a few slides, then pause on a particular topic, and then certainly happy to answer questions after. I'll go through quickly here. So the rough outline of the presentation as you all review really starts at the bottom, so core foundations, and a lot of that is what Megan talked about. The federal regulations and then state regulations that really provide the foundation for what's in Medicaid, what's not in Medicaid. That really is the basis for how we set the capitation rates. Then the specific KanCare program design, so focused on the managed care program. There is also a small portion of the program that is what we call fee-for-service, so that's where the state is paying providers directly. That's for some unique populations and services. For all intents and purposes, the KanCare is a comprehensive program covering all populations and all services in the Medicaid program. And we'll talk a little bit about the design of the program, the components of managed care that are important to consider in terms of efficiency, competitiveness, and some key concepts. And then the detailed portion there, which we may not get too far into today, but I'll make sure I answer some of the questions here, gets into what we'll call the kind of the nitty-gritty of how do we get to a capitation rate, what sits behind that. So we'll hit on this one very quickly. The primary foundation is the Social Security Act, Titles 19 and 21, that defines Medicaid and defines CHIP, the Children's Health Insurance Program. That's really going to be the basis for who's eligible, what the services are in terms of what the federal government will provide assistance for. So that's the FMAP portion. There is an opportunity for states to use state-only funds for whatever they deem appropriate, since that is at the discretion of the state. But in terms of federal funding, following those rules, Center for Medicaid or Medicare and Medicaid Services, the primary regulatory oversight committee, specifically 42 CFR 438. That's going to give the definitions and why actuarial soundness is important. And within that, then the state can define how they want to structure their program. So if you know one state's Medicaid program, you know one state's Medicaid program. Every state is a little bit different. And so today we'll focus on the KanCare program. As we talk about capitation rate setting, there's really four, we'll call it determinants of risk for the program design. It's your who, your what, your where, and your how. Yes.
I'm sorry, but I'm finding you a little hard to hear.
Oh, sure, I can.
Put the mic a little closer.
Sure, I'll get really close to it. Is that better for everybody? Wonderful. So who's covered in the population, what services and reimbursement, where, the networks and the regions, and then how, doing managed care versus fee-for-service. And we'll get into some specifics of how the KanCare program is designed and how that compares to other states. Let's get this here. I'll highlight a few slides here in terms of the major takeaways of really kind of three big components today. The first is, as Megan talked about, actuarial soundness and FMAP. CMS requires, and the federal government requires, that the rates are actuarially sound in terms of providing that federal assistance each year. So every year, we have to certify that the rates are actuarially sound. And we do that for what we'll call a contract period. I'll clarify here, the contract period is specific to each annual period that is contracted with the health plans. And so they may be eligible for a 5-year contract with the state. However, the capitation rates are set annually, very similar to how you may have a commercial insurance, a car insurance, a homeowner's insurance. You know, it's updated annually. And we'll talk about the importance of that and how that plays into actuarial soundness and some of the questions on that came up earlier as well. The specific definition for actuarial soundness: reasonable, appropriate, and attainable. So reasonable being moderate, not too high, not too low. And really, one of CMS's requirements, given we're using taxpayer dollars, is they are efficient. So that plays into the moderate discussion. We don't want to be overpaying the plans. We also can't be underpaying them. They also are, as an insurance company, are regulated by the National Association of Insurance Companies, and they've got their own regulations to make sure they can actually operate as an insurance company. And so that's an important piece of the puzzle here as well. Appropriate, the next piece, is making sure that they are aligned with all state policies. So they're covering all the services, all the populations. They don't include anything that isn't covered. And they are aligned with, again, state policies being both benefits being the services they can get, and the reimbursement, which Megan talked about and we'll talk about a little bit as well. And then attainable, meaning making sure they're aligned with all of the quality and access to care components as outlined in the state, as well as any, we'll say, kind of unique external factors that may be going on in the healthcare system to make sure really we're setting a rate that is reasonable, appropriate, and attainable. So I'll pause here. Madam Chairperson, would you, I guess I'll ask here first, would you like me to pause maybe after a few slides and take questions? Or
Would. I think that's
Sure,
perfect.
Perfect, great. So I can pause here and see if there's any questions on just actuarial soundness here or some of the general foundations.
Just a minor correction. You said that these insurance companies are regulated by the National Association of Insurance Companies. It's actually the National Association of Insurance Commissioners.
Thank you.
And they do not regulate insurance companies. The Kansas Insurance Department does.
Thank you for the clarification.
Just a clarification.
Yes, thank you.
Respect so much what the actuaries do, and I can only imagine, I know many actuaries, how difficult it is. Much like weathermen, they can make a mistake and everybody goes, oh, well, shucks, darn. I guess it did rain after all.
Yeah.
You guys make a mistake and we're talking millions of dollars right here. So we really appreciate what you do. Can you tell me how right on you have been for the state of Kansas the last few years as far as what you predicted and as far as what the claims were?
Sure, yeah, that's a great question. So really the way that we'll measure we'll call the accuracy of the capitation rates is, and one thing I'll make a point here as well that kind of plays into that in terms of actuarial soundness, it's on a prospective basis, so it's more process than result. However, we always look at the results to make sure our process is working. If we see a particular year, we were much too high, much too low, we may need to modify the process, modify an assumption to make sure we're always trying to find that perfect balance there. So I can get the specific numbers for the last few years, but I want to say generally our target, so what we actually price into the payments, is a 1% profit margin. So fairly slim. That is about as efficient as you can get in a Medicaid program. And you may compare that to other, on the commercial side, you'll see obviously profit margins much higher than that. That doesn't mean they are limited to that or that they are guaranteed that amount, but that is what we price in prospectively. And so that's really what we'll then look at each year to see how close did we get to that by plan, but also by program. And I want to say within the last few years, we've been, I know, in the low single digits for profit. It kind of varies by plan, but across the program, we've been fairly close. So we've been working in the Kansas program for quite a while, so I've got a good handle on where things are at. It is always predicting the future is difficult, but again, that's why we do this annually, and we may even have what we call mid-year updates to make sure we're accounting for what's going on in the program.
That's interesting, a mid-year update. Okay.
Yep.
Also, as an actuary, a group of people, a group of beneficiaries could have a very healthy year. And you're like, but it doesn't mean you were way off. It just meant the next year could be a catastrophic year. So it has to be over a period of time to kind of look at that to see how well the actuaries did over a period of time. Thank you so much for answering that question. Representative Carpenter.
Yes.
Thank you, Madam Chair. So, and thank you for being here. So you meet twice a year, spring and fall.
Mm-hmm.
And when that comes out, then that's in the form of caseload. Is that correct?
Are you talking about for you all when you guys meet for caseload? Yep.
So many of you that have been here a while, I have a big problem with this because we don't have any legislative input in this. You meet with the MCOs, research, and yourself, and then you get a bill, and we get the bill, and we don't have any. So I had a proviso in the budget several years ago that said we would, there would be a legislative people involved in that. Social Services Budget Chair, Appropriations Chair, nobody would meet with us because they did not want us to be involved in that process. And I've always been, it's been one of my pet peeves. There are 6 states, and I was going to ask, do you have any states that are has legislative involvement in the process, your actuarial process?
I may have to follow up on that one. I personally primarily work in Kansas and Colorado, but we do have other states and other teams that work on that, so I can follow up on that. I know some states have what they call a joint Medicaid Oversight Committee, so they may have, it's not necessarily the Medicaid program, it's not the legislature, it's kind of in between that is kind of helping oversee that and gets a little bit involved there, but I can follow up on that question for you guys.
Years ago, there were 6 states that had this legislative committee that oversaw this because, and the thing that triggered this for me was that I got a as Social Service Budget Chair, we got a $400 million increase. And all I could say, and in caseloads, and all I could say, it was a per member per month deal and the capitation rate went up. That was the only explanation that I could get. And I've always been frustrated with that because we're paying the bill and yet, a bunch of folks, I'm not saying anybody's dishonest or anything.
Sure.
But I'd sure like to be involved in that process. And since then, it's been fairly stabilized, 100 million here and there, which is not that much. But I'm still frustrated with not being involved, have the legislature not being involved in that process. So.
Senator Peck?
Thank you, Madam Chairman. You mentioned in your relationship, on your relationship page, that you are currently the actuarial vendor for the state of Kansas.
Yes.
So I'm going to guess that's done through some RFP, something to that effect. So I have 2 questions. How long have you been the actuarial vendor? And number 2, how much is it costing the taxpayers of Kansas? What is your fee to be an actuarial vendor for the state of Kansas?
Sure. So we've been the actual vendor for Kansas since 2012, with one caveat. I believe between 2016 and 2018, there was another vendor that was in, but we've been in it, might even be slightly earlier than 2012, so quite a while. Even pre-KanCare, and we actually assisted with the implementation in the beginning of the KanCare program. In terms of the specific number for the budget, I can make sure I follow up with you on that particular number. But we do it through a procurement process, a competitive procurement process. So every 3 to 5 years, depending on the contract, and sometimes there's optional years. So if we're doing a good job, hopefully we get those optional years. But yeah, they do follow that procurement process. Yeah.
When you say provide that information to me, I'm hoping that's staff, so staff can provide it to the entire committee.
Yes, sir. We'll provide it to the committee. Yes, yeah.
Representative Ballard.
Thank you, Madam Chair. And thank you very much for being here today. You indicated you meet twice a year. And our consensus estimate, people meet April, November. Is there any interaction between that group and how you arrive?
At the capitation rates, yeah. So I'll provide one quick clarification. So the caseload process, I know, happens twice a year, the spring and the fall. We actually meet weekly with KDHE to make sure we're staying up to speed on everything going on in the program throughout the year. And so we have constant contact, even meetings during the week, emails. So we're really involved, not quite in the day-to-day operations, but very closely to make sure we're staying up to speed on everything that's going on in the KanCare program.
That's the reason I was asking, because I thought you met more than twice a year, because twice a year would not give you enough if you were not meeting with the different agencies to find out what was happening in the process. So that's why I asked that question. I think you heard from Representative Carpenter that there are 6 states that allow input from legislative. I had asked that question before, and someone basically said they didn't want legislative input. And part of that was we have an opportunity to address it later on. Even though they come up with it, we can address it. If it's only 6 states, it would say to me, we have 50 states. And that's a minority group that's allowing that to happen. And I'm wondering if it's because they have specific concerns, or for what reason. I guess the question, I'll just be blunt about it, is there a problem why legislative input is not considered, or do you consider working with the different agencies and everything else to get the information? You have legislative, not legislators' input.
Yeah, so to answer the latter part of the question, yeah, we do make sure that we're in constant contact, making sure we're getting any kind of legislative information coming out, particularly around any policies, whether that's changes in benefits, changes in eligibility. The primary one is changes in reimbursement, like Megan talked about, and we'll talk about as well. So we do make sure we get all that information through the state agency that we work with.
Thank you, Madam Chair, and thank you.
Please proceed with your presentation. Thank you so much.
Thank you, Madam Chair. So I'm going to skip ahead a few slides to get into a little bit around the KanCare program. And one of the reasons why, or a few reasons why, you may have capitation and how it functions in the state of Kansas. So one of the primary reasons to have a managed care program is to transfer financial risk from the state to the health plans. So as we set a per member per month, if you know what that is and you know reasonably where enrollment's going to be, that effectively gives you a sense of what are you going to pay for the next fiscal year. In the absence of that, then the state is really on the hook, and the state is at risk for whatever happens and whatever shows up in the Medicaid program. We can still do some predictions, but it's effectively transferring that risk, so then the health plans are at risk for managing the care. And it is a, we'll call full risk prospective program. So we set the rates prospectively. So for example, the 2025, calendar year 2025 rates, we set last fall and negotiated and contracted those with the plans before the beginning of the period. And they are fully at risk for whatever happens in the program, good, bad, or otherwise. Which really then incentivizes them, this will get to the efficiency piece, they want to make sure that they're managing the care to that amount. And that really gets to a key tenet, which is the competitive nature of the managed care program, and one of the components that really looks to drive continued efficiency in a managed care program in general. So in Kansas, in the KanCare program, there are 3 national health plans. They each all have about a third of the enrollment, give or take a few percentage points. And when we set the capitation rates, each plan effectively gets the same rate for each individual population. That may, if you aggregate that up, they may get a slightly different overall rate, and I'll talk about how that functions and why we do it that way at the individual rate cell level. But they all effectively get the same rate. And so they're all effectively competing with each other to be efficient to beat the average. Hey, if I can contract slightly better than my competitors, or I can be a little bit more efficient, reduce emergency room utilization, reduce unnecessary inpatient readmissions, they as the health plan can beat the average and be profitable. That benefits the program because then we're constantly using new data to set what that prospective rate's going to be. So as they are efficient over time, that's really our new starting point. So not only do they have to beat their competitors each year, but they're also competing against themselves historically to continue to be efficient over time. There are some components to make sure we don't have a race to the bottom situation, which we certainly do not want to have in terms of not providing services appropriately or cutting benefits, anything like that. The plans don't have control over what the benefits are. There are a lot of quality measures and oversight components to make sure that they are providing services appropriately to members. And there's also I think as Megan talked about and I'll talk about here, a minimum in terms of where they can contract with providers. So making sure they can have an adequate network, so members have appropriate access to care, and through that, having that minimum reimbursement that can be provided. And that's really a key component because as increases or decreases are passed, particularly for, through the legislature for a service, we have to account for that in the capitation rates because that is a key tenet of actuarial soundness. That was the appropriate component, which is it accounting for that minimum level of reimbursement? And so if there's $50 million for hospitals that's passed per particular year, we have to increase the capitation rates. The health plans then, because that increases the minimum, they have to pay that to providers. So that does not generate $50 million in profit. They don't get to decide, I'm just going to keep this, I don't need to pay it out. They have to pass that on to providers. So just want to make sure that's clear here and that actually does go to providers as intended and is not just held onto by the plans. So I think I'll pause here again for a few more questions.
Representative Carpenter.
Thank you, Madam Chair. And so when you're talking about this risk, it's only for 6 months because then we readjust it spring and fall. So if a MCO has a higher capitation rate, they pay more at that point in time. In the fall, you adjust that rate up. Is that correct?
I'll provide a quick clarification. So I'll kind of delineate the contracting with the plan process versus the state caseload budgetary process. So you're right on the budget side. You guys are looking at the budget twice a year, spring and fall. We actually set the rate annually, so they get a fixed rate for 12-month period, the calendar year period. I believe what the state's looking at is just monitoring that enrollment level because that's really what's going to drive how many payments you're making, which is than what the state's budget is going to look like. And so I think they look at that twice a year to keep an eye on that. The capitation rates are set prospectively for that 12-month period. I did mention we do make mid-year updates. The key component for that is really any policy changes, because the state's running on a fiscal year basis. So starting in July, the capitation rates are on a calendar year basis. So really the only adjustment we make at mid-year is for any state policies. We don't adjust any other prospective components. So we're not looking at, hey, you're losing a lot of money, we got to add money to the program. They're still at risk for that for the year, or vice versa. If they're being profitable, we don't bring them down. That's the full risk nature of it. So the resetting of the rates each year, or the rebasing we may call it, is really on that calendar year basis. But we do make sure we account for any of those legislative changes that happen at the 6-month mark. Yep.
Representative Bryce.
Thank you, Madam Chair. Thank you, sir. Had a quick question. Actuary professional, just to clarify for me, are you epidemiology trained, statistician, CPA? What exactly background is?
Great question. I'll go back a few slides here. I'll have a few pieces here. So there is actually a credentialing entity. It is the Society of Actuaries. You can be an associate or a fellow. At either level, you can effectively perform all the roles of an actuary. A fellow may be just highly specialized in a particular area. It is a series of, I'll say, very rigorous mathematical exams, statistics, insurance, a lot of other components. It's got about a 60% pass rate, so fairly low. It's very challenging. And it's about we'll say 4 to 6 year process. Some people are faster, some people are slower, things happen. So there's a fairly rigorous credentialing process, and then there's the American Academy of Actuaries as well that you belong to be able to make sure we're keeping up with all of our annual continuing education. We're also held to actuarial standards of practice similar to kind of accounting general practices. So.
Thank you. Madam Chair, if I could, just a quick question. So you're basically managing risk. You're using mathematical models for a lot of this. I know seems like every 5 or 6 years there's a major, like a pandemic or an epidemic. There was COVID, there was Ebola, swine flu. I remember when AIDS came out. These are unpredictable things that somehow I would assume you would have something in your structure of your model to predict, maybe you can't predict, but one thing I know that would upset a lot of particularly the profit margin of 1%, et cetera, and then these things would go up or down. The fee-for-service type payments, if there's an event, a healthcare event, seems like that would increase profits. For the provider, the capitation patients would have more services, so you might have decreased profits. But do we have two models of reimbursement like that to kind of mitigate against these unforeseen risks in the future? Would that be fair?
It's a great question. So you're right, those are very hard to predict. We wish we were better at it, but it's very challenging. So there is another component that can be layered in on top of the full risk capitation called risk mitigation. There's a few different ways that can happen. The most common, and I'll actually use COVID as an example, and the state actually implemented this during COVID. We call it a risk corridor, which basically narrows the level of risk that the health plans are at risk for. And that was implemented going into the pandemic, or I guess as it came up, it was probably June or July when that got implemented to really narrow the risk in the program one way or the other. So we didn't know what was going to happen. In this case, even though there was a lot of folks needing care, a lot of things got shut down, and so we saw actually reductions in overall utilization, which then would have turned into just profit for the health plans. But because we narrowed that, the state actually was able to recoup some of that profitability from the health plans If it had gone the other way, the state might have had to, pick up some of that additional cost. But there is a way to, we don't necessarily prospectively build that in every few years, but there are ways to, if we know it's starting to happen, that you can add some additional components to the program to help control for that.
Okay, thank you very much.
Thank you. Please continue.
Thank you. A few additional pieces I'll mention just around efficiency components. So one of the other reasons you may have a healthcare plan is to delegate some of the administrative components that the state does, some of the more, we'll say, basic things, paying claims, doing provider networking, member appeals, things like that. But we also will engage with them to do some of the more complex things that they would be the experts at, if you will, in terms of managing the care, doing care coordination, utilization management, care management. They'll have teams of nurses and healthcare providers to make sure they're doing outreach and connecting with members. Hey, we saw you were discharged from the hospital. We're making sure you have everything you need. Hey, we saw it's been a couple months since you've refilled your prescription. You want to make sure you're getting what you need. You're adhering to that. So they'll do those things to make sure they are, again, being efficient. They all want to make sure they're beating the average, and so they can do some of those administrative and care coordination pieces to continue to help improve not only from a financial perspective, but improve the quality outcomes for the members in the program. We can also build in some cases, a prospective efficiency adjustment, which we have been doing the last couple years, where we've got analytical tools that will identify adverse events, potentially avoidable complications, and we will actually prospectively build in a slight reduction to the capitation rates to say, hey, these are areas that we're seeing happen. We'd like you to address these. We're going to prospectively adjust the rates down, kind of lowering your target for you to either address those specific areas or some other area. But we're using that financial tool of, hey, we're going to pay you slightly less because we want you to go out and improve some of those areas. I talked about the administrative piece here, and then slide here. So slide, I believe 16 is just a high-level informational graphic, not specific to the KanCare program, but it wanted to illustrate the sort of long-moving train, the long-term component of managed care, which is really what we call bending the cost curve. And so in this particular case, what you'll see is the FFS, that's fee-for-service, so that's the absence of a managed care program. The first couple years you may see, it's maybe a little bit hard to see here, but could be maybe actually slightly less expensive than managed care, because we're paying for some of those additional administrative care coordination, utilization management things that maybe not have taken place otherwise. However, there is a long-term return on investment, if you will, for that. If the plans can keep costs lower, let's say they progress at a 2% increase, whether that's utilization or reimbursement. If fee-for-service was only at 3%, so only a 1% difference, over time, you're going to get that compounding effect where managed care is, in this case, theoretically, saving money relative to where fee-for-service was. The fee-for-service is, we don't have fee-for-service now. We don't know exactly what it would have been. But there is a concept of efficiency over time that's already embedded into the capitation rates themselves. And with that, I'm going to actually jump to, I believe here, so a lot of numbers here. This is, can't see the slide number here, but wanted to talk a little bit about some of the questions that came up, some of the rate cell structure. This is not a comprehensive list of all the individual rate cells, but these are the general populations that are covered. Within each of these, there may be some additional splits for age, so kids versus adults, things like that. But this will give kind of a general outline of the various populations that are covered in the program. The PMPM, that's the per member per month. Enrollment is historic enrollment, so really just for informational purposes, more for scale by population. and then some percentages that I'll get into here. But what you'll see is pretty wide range of the per member per month. So CHIP, that's going to be your the Children's Health Insurance Program. TANF, again, is going to be TANF adults or kids. Pregnant women, you know, we're seeing them in the $300 to $400 range a month, generally healthy. Then you're getting into foster care, $1,000 a month, and then we get into HCBS, which is the home and community-based service waivers. LTC is long-term care, so these are members that are actually living in a nursing home, and you can see the costs begin to get quite a bit higher there. And this will really be an important concept, not only wanted to share just so you can visually see what this looks like, but also why we have these rate cells and how we get to different rate cells. And really what we're trying to make sure we do is match payment to risk. So what is the risk the health plan is taking on based on the members they have enrolled? So we'll scale the payments to say, hey, you have 1,000 long-term care members, you're going to get 1,000 payments of $6,000. You have 100,000 TANF members, you're going to get 100,000 payments of $400. Whatever their membership is, it will scale appropriately, so we're paying them based on the members that are enrolled. And that's really the big reason why we have these different rate cells. And I believe one of the questions was how do we get to the definitions of that? How do we determine what are the rate cells and who goes into which rate cell? So it's all going to be prospective, and it's all going to be generally based on their eligibility. So we'll say kind of level 1 is, do you qualify based on income? And maybe that's it. That's likely going to be in your TANF or CHIP, depending on where their income level falls. Then you get into additional pieces. Hey, do you have an extra disability? Are you physically disabled? Are you aged? Are you blind? That's going to be that the ABD and the SSI populations, which are generally a bit more expensive. And then from there, the next level up is there'll be assessments that are done to determine if you have a particular level of care that aligns with requiring an institutional level of stay. So do you need to actually be in a nursing home? Or in lieu of the nursing home, can you receive home and community-based services in your community? So that is really the determining factor for where they will land, and we use those different criteria to develop the rate cells because they generally also align with their anticipated costs, generally healthy, kind of moderate, or very high cost. And that also makes sure then when we set these different rate cells and have this delineation, we can match that payment to the risk of the health plan. And I'll have another slide that gets into why that's very important and how sensitive it can be, but that's the general concept there. So I'll pause for questions here, yes.
Seth, I think we have one question here on the chart. Representative Carpenter?
Yes.
Thank you, Madam Chair. And I hate to pester things, but this is total dollars, right?
So yes, it's good. Yeah, yes, this is total, federal and state, yes.
Our percentage is 40%. The feds is, just so we're clear to everybody, this is total dollars.
Yes, that's a great clarification. So yeah, when we do set the capitation rates, we are using, we'll say kind of an all funds basis. What does the health plan receive? And then the state on the back end will claim their portion after they've made the payments on a quarterly basis.
Thank you. Please proceed.
Sure. And actually, I'm going to jump ahead to slide 32. So shield your eyes here while I scroll through, because I do want to hit on that very important concept of why we vary it and why we don't necessarily pay just one fixed rate for each individual health plan. Here we go. So this is just a high-level example, kind of a simplified example, but we think very powerful to explain the importance of this. So we'll say 2 rate cells in this hypothetical program. Rate cell 1 is maybe more of a TANF population, CHIP, generally healthy, $200 a month. Rate cell 2 maybe is a long-term care, HCBS, $5,000 a month, very expensive. And we'll see that rate cell 1, population 1, usually much larger. That's consistent with the KanCare, and really every state, the TANF and CHIP population is the large majority of their population. Long-term care, much smaller population. And so going down to the next line, we'll say scenario 1, statewide average. And what that's doing is taking the weighted average between rate cell 1 and 2 based on the membership, the enrollment. So in this case, it's about 95% on rate cell 1, about 5% on rate cell 2. Applied to the PMPMs, you get about $430. And in this scenario, for each of the hypothetical MCOs, MCO1, MCO2, they each have a slightly different proportion of enrollment, but we pay them the exact same amount. Let's say, hypothetically, they each get $430 because, hey, that's the overall statewide average. Scenario 2, we say, well, let's actually match payment to risk. Let's actually match the rate cell to the enrollment and vary their aggregate level of payment. They'll still receive individual rate cell payments, but if we roll it up to see what is their overall average across the program. So in this case, it's based on each of their individual enrollments. So the 600,000 rate cell 1, the 400,000 for rate cell 1 for MCO2, and then about the even split there for rate cell 2 there. It's really not a big difference in distribution. So it's maybe, it was 95 and 5 for the statewide. MCO1 is maybe 96% and 4%. MCO2 is 94 and 6%. So only maybe about a 2% difference, not a big deal. If, though, we apply that to the payments and the enrollment, what we'll see is, well, MCO1 under scenario 2, because they had a higher proportion of those lower cost members, they should have only gotten paid maybe $390 a month aggregate. And MCO2, they had lower of the lower members, and so higher of the higher members, they should have gotten $480 a month. And so that 1% or so difference in distribution resulted in a 10% difference in payment by plan. One plan got paid 10% too high. They're loving it. Don't tell anybody. MCO2 is getting paid 10% too low. They're probably going to show up to the state with a team of lawyers and say, we got to fix this. So that's really why we have so many rate cells, is to make sure we can match payment to risk. So we're being efficient with how we're paying the plans. We're not inadvertently over or underpaying someone purely based on the enrollment that they get assigned or that members choose from them. So again, I'll pause here on this slide, see if there's questions on this concept here.
Representative Ballard.
So you have the different levels, but what input does that individual have? I mean, are they placed there just by how you see them, or do you compromise?
In terms of which rate cell they get assigned to, is that the question?
Yes.
So that's based really on their, we'll say, eligibility criteria. So we as the actuary are not necessarily assigning where the member goes. That's really done by the state and really their eligibility team and the eligibility vendor. They'll look at, as the member applies to Medicaid or remains in Medicaid, what is their particular demographic and it's kind of disease or level of care criteria. So one, obviously meeting the minimum income. Two, hey, are you receiving any kind of disability income from Social Security? Maybe you have a disability. Okay, well, we know that's generally going to be higher. You're going to be put into that population. Or, hey, we see you have a nursing home level of care. Someone's done an assessment. You need to go or are already in a nursing home. You're going to be put into that particular population. So it's really based on that criteria prospectively. And then we group those members and look to see, for this group, what is their average cost? And that's what will determine the capitation payment.
If I may, Representative Ballard, clarify for me, but the individual never knows what rate cell that they're in, because this is just has to do with the actuary determining, we think this person is going to utilize this much services, this many dollars, and that's how much is paid to the MCO, but the individual just picks an MCO and it's going to be the same rate determination, but the individual never knows.
Well, thank you. My next question, do they know where they're placed?
Right.
And you just verified that, because that's why I asked, do they have any input? And
Member, yes, I
because
see.
I assumed you just placed them and they didn't have any input, and you're basing that a lot on their risk factor. And they don't really know that. But then at some point, do you ever tell them where you put them? Or do you shift them in and out based on annual?
Yeah, really, the timing is kind of member specific, but yeah, I don't believe they ever know. Not that it would impact things one way or the other, but really it's, like you said, Madam Chairperson, they're enrolled, they're eligible for whatever services they need, and that's what they can go get. So even in the example of, I'm not a nursing home level of care, I'm a generally healthy adult, but something happens and I need to go to a nursing home. The rate cell happens on the back. They can use all those services as much as they like to. There's no limitation within any particular rate cell on the services they can get. This is really only on the backside to make sure we're scaling the payments appropriately, really between the state and the health plan.
Gotcha. Thank you, Madam Chair. Thank you.
Please continue.
Great, thank you. So I'm going to go forward slightly here. So I'm going to go just one slide ahead to talk about what we call the base data. And actually, let me go back a few slides here. Sorry, I apologize, everybody. I'll hit on the overall flow and the process of how we get there, which I think will also answer a few of the other questions that came up before. So in general, this is the flow of setting a capitation rate. It's not proprietary to Optimus. If any actuarial vendor will have effectively the same flow here, again, because we're guided by federal regulations, state program design, actuarial standards of practice. Everybody's kind of following the same rules. The biggest driver of the capitation rates really is that first step, what we call the base data. And this is where each year, so because we have those annual capitation rates, what we'll do is we'll collect the most recent information that's available to us, the last 2 to 3 years of information. And that's really the basis for how we set prospectively. We're always looking at what's going on. So we used kind of this year and next year as examples. Last year, kind of in about this time of year, we're setting the 2025 rates. We're using 2023 and 2022 data. Going into this next year, now we're setting the 26 rates. We'll use 23 and 24 data. So we're always moving the data forward each year, the same way we're moving the capitation rates forward each year to make sure we're keeping up with as close as we can, the most recent information we have on what do those cost profiles look like for each member, what does reimbursement look like for each member, and utilization of services. And actually, Senator Erickson, I'll answer one of your other questions, I think, on the PPS question. And so that would include, that data includes the entire suite of services that the member is eligible for. And all of those services are all included in the capitation rate. So regardless of how the provider is reimbursed, that data and that cost is captured in the capitation rate. So kind of from state to plan, it's one payment. Then from plan to provider, that will be based on their particular agreement and their structure of their payment. And so a few examples, again, the doctor's office, depending on what services you get there, they'll bill based on that and the plan will pay. If you go to a nursing home, that's generally just on a per diem basis, and so they pay per day. Or the PPS question, whether it's federally qualified health clinics, which get a PPS payment, or the CCBHCs or CMHCs that also, or I guess CMHCs don't, but CCBHCs get a PPS payment, that's also captured in there. So it's all one payment that the plans get, and we're looking at the volume of the services they got, the cost of those services, and that's really what feeds into that per member per month there.
Seth, I have a quick question for you. Do you feel that the application that Kansas uses for qualification for eligibility for Medicare, or excuse me, for Medicaid, is adequate for you to make these determinations on rate cells?
I believe so. We've not really had any issues with that in the past. So I know they're also constantly reviewing that. There's an entire team that's doing that on an ongoing basis. And if there's even changes in that, we initially thought they were in rate cell 1, but upon further review, they actually should have been rate cell 2. We're getting that information constantly to make sure we're aligning that appropriately.
Very good. I know some states are taking a look at their application because they felt like that maybe had they had a deeper dive into the individual's health background, et cetera, that they might have been more accurate in their predictions. Committee, we're wrapping this up. Any additional questions? Okay, one more.
Thank you, Madam Chair. Just one very quick one. So when you were talking about your annual, is that on year to year?
Yes.
January 1? So the state fiscal year is different, but it's, okay.
Yes, yeah, and that just goes back to the original implementation of the program. It just happened to be on a calendar year instead of fiscal year basis. Some states do fiscal year, some do calendar, some do federal fiscal. So, but we keep that constant. The difference there, because they're not quite aligned, which is fine. That's why we have that we'll call kind of mid-year adjustment. So, right now we don't know what next fiscal year's policies are going to be, but as they come around, we'll make some of those adjustments as they come up.
As of July 1, our budget reflected what you entered into on the 1st of January.
Yes, yep.
Okay, very good. Thank you.
Thank you very much.
Yep, thank
Committee,
you.
we're ready to move on to our next presentation from KLRD, overview of the legislative additions for KanCare 20 through 25. Committee, I just want to mention that this report that Representative Carpenter mentioned has been sent to your emails as a PDF. And you're getting paper copies. Thank you, Megan.
All right, there are 3 items that are being passed out. The first one is the medical assistance report that Representative Carpenter referred to. This is a detailed description of all the various eligibility categories, the capitation payments. It's updated each month by the agency, so you can find updated copies online each month. But it's a really nice breakdown of the program and the expenditures. The next item is some information about the disproportionate share hospital. I misspoke, so I want to apologize. That does not cover uncompensated care. It is strictly for Medicaid patients. And then the last item is in response to Senator Peck's question about the Medicaid financing. It is a table that outlines the actual expenditures for the major Medicaid programs for the last, I believe, 10 years. And then I'm going to be presenting from the legislative additions table. And I'll remind you of the chart that I showed that had the expenditures. And there was a question from the committee about why the expenditures were going up and that the population was not going up at the same rate. And I believe this will help answer your question. This also answers the question about the state policies. So in the slide that I had, that was the state policy category. These are the state policies. So these are the changes that are made to the program on a state level. So
I'm sorry, I'm not seeing that handout. Is it still coming or?
Yeah, it's in the packet. This was in the original packet.
Okay, thank you.
Yep. So it starts in 2019. In the 2019 legislature, you can see added 19.2 million SGF in expenditures to the Medicaid program. So these are generally rate increases, some changes to the PACE program. And then in 2020, which was of course the year of COVID, there was 1.2 million added SGF. In 2021, that went up to 66.7 million. And the largest increase in 2021 was a 75.2 million or 26.3 million SGF that provided a $15 increase to the daily reimbursement rate for nursing facilities. And there's also a 12.4 million addition for the IDD waiver for a provider reimbursement rate increase. If you flip that over, you can see that in 2022, the additions rose pretty dramatically to 115.2 million. And the largest items in there were a 25% reimbursement rate increase for the Medicaid code for specialized nursing care. That was for the IDD waiver. And there was a 36 million increase for a rebase of the nursing facility daily rate. In 2023, there is an addition of 116.6 million. And the largest additions there were 34 million SGF for community mental health centers. This was to convert, help convert the CMHCs to the CCBHC model. There are 32.9 million SGF that was added to rebase the nursing facilities. And then 24.6, and that was for payments to nursing facilities based on the number of Medicaid residents. So this is the nursing facility add-on, is what we often call it. In 2024, the legislature added 103.1 million SGF to the Medicaid program. The largest additions in that year, or that session, were 20 million for Medicaid outpatient hospital provider codes. There's also a 12 million SGF add for physician provider codes. There's an 18.6 million SGF add for personal care services on the frail elderly waiver. 18 million Medicaid added on for the nursing facilities. And then 6.7, and that was to add 250 individuals from the wait list to the IDD waiver. And then if you flip it over, you can see the additions from this last legislative session. And again, that Medicaid add-on was one of the largest additions, and that was for nursing facilities. And there's a $5.4 million add SGF to add 200 individuals to the IDD waitlist. So Representative Bueller, to answer your earlier question, one change that has been made is that we've added quite a few people to the IDD waiver from the waitlist. So that has impacted. It's not the only impact, but that's one. I'm happy to stand for any questions about the legislative add-ons.
Seeing none, you may continue.
Okay. All right, I'm going to move on to the caseloads overview. The caseloads, as you know, are estimated. The new estimates are made twice a year in October and April. These estimates that I'll be talking about are those that were made in April. When you hear me talking about...
Megan, are you on this one?
Oh, I'm sorry, no. I am on a caseloads memo.
Thank you.
So when you hear me saying that the expenditures have increased or decreased, what I'm comparing this estimate to is what was approved by the legislature in the 2025 session, so Senate Bill 125. This year was a little bit different. In general, the new caseload estimates will be implemented in the budget. This past year, or this past session, they were not, and so the numbers that I'm providing today have not been are not included in the budget. So when you hear me doing those comparisons, that's what I'm comparing to. So in 2025, the revised estimate for all human services caseloads is 5.5 billion. That's 1.7 billion SGF. And this is a decrease of 57 million all funds, and that includes 35 million SGF. The temporary assistance for needy families, this is the cash assistance portion of TANF only, saw an estimate of 9.5 million. This is all federal funds, and it's a decrease of $200,000 from what it was approved in the budget, and that's due to a reduction in the number of anticipated participants. For foster care, there was a decrease of 3.9 million all funds, and that is an increase of 10 million SGF. The SGF decrease is largely due to a decrease in the projected savings from the relative licensing policy. This is a policy that was anticipated to create some savings within the program. Those savings have not been realized as anticipated. There are also revised estimated costs for case management providers. For KanCare, this includes the medical expenditures for KDHE as well as the mental health and long-term care expenditures for KDADS. The estimate is 5 billion all funds. That includes 1.3 billion SGF. This is a decrease of 53 million all funds and a decrease of 45 million SGF. The all funds decrease is due to new estimates for the capitation payments. This is largely because population increases were not as high as we anticipated in the fall. So in the fall, we anticipated the population raising at a certain rate. That was not realized. The population rates actually rose at a lower rate, and so we saw a decrease there. The SGF decrease is largely due to an increase in the HMO privilege fee revenue. That was about $26 million, and that is a fee fund that is used to offset SGF expenditures. So as that fee fund revenue increased, the SGF expenditures were offset. We also saw some decreases that were partially offset by increases in fee-for-service estimates. So fee-for-service payments are those payments that are made directly to providers. There are certain services that are not included in the MCOs that are made directly from the state. And there were also some policies that were not yet included in the capitation rates. And KDHE is going to go over these in detail, so I'm not going to go over them in detail right now. KDAD's non-KanCare is 133 million, and that includes 66 million SGF. This was no change from the prior estimate. So for fiscal year 26, we have a revised estimate of all caseloads as 5.8 billion all funds. That's 1.8 billion SGF. This is a decrease of 46 million all funds, and that includes a decrease of 13 million state general fund. For TANF cash assistance, it remains at 9.5 million. Again, that's all federal funds, and this was a decrease of $200,000. Also, same as in fiscal year 25 due to a reduction in the number of participants. For foster care, there was a decrease of 5.2 million all funds. There's an increase of 16.8 million SGF. The increase in SGF is attributed to the governor's executive order to allow SSA and SSI benefits to remain with the child in their ABLE account rather than offsetting SGF cost of foster care. There is also the removal of expected SGF savings due to that relative licensing policy again. For KanCare Medical, the estimated cost is 5.3 billion all funds. That includes 1.5 billion SGF. This is a decrease of 45.6 million from all funds and 32.5 million SGF. The all funds decrease, again, is due to population not rising as we anticipated in the fall. The SGF decrease, again, is largely due to increased HMO privilege fee revenue that offsets that SGF costs. In fiscal year 26, the estimate included a decrease in the FMAP from fiscal year 25, as you saw in my earlier presentation. This did not impact these estimates. That savings or I'm sorry, that increase was accounted for in the fall estimates, but just as some context to how the FMAP helps the difference that those incremental changes in the percentage make in the actual costs. The decrease in the FMAP from 61.64% in fiscal year 25 to 60.97% in fiscal year 26. It was a change of 0.67%, but it was an increase in the state share that amounted to $30.4 million. And then lastly, for fiscal year 26, the KDAD's non-KanCare, the estimate is 144.2 million all funds, and that's 72.7 SGF. This is an increase of 4.9 million all funds and 2.7 million SGF, and that is related to revised provider contract rates for IDD, physical disability, and the frail, elderly, and brain injury assessments. So those are assessments for the waiver. And I'm happy to stand for any questions.
Lots of information, Megan. Thank you so much. On committee questions. If you have any questions later, you can reach out to Megan. Go ahead, Megan.
That concludes my information.
Thank you. Committee, next we will move to the agency presentations and agency overviews of changes and additions. We'll start with Christine. Welcome.
Good morning, members of the committee. Christine Osterlund, Deputy Secretary for Agency Integration and the State Medicaid Director. I'm going to go just a tiny bit out of order just so I'm not into the slides and then I transition to a handout. So one of my items was talking about caseloads. It looks like this. It was an ask of looking at things that KDHE took to caseloads from 2020 through 2025. So I won't go through these individually. Happy to answer any questions if there's an individual item that anybody has questions about. One thing that I will say that we've added over the last couple years, you'll see starting with the caseloads in 2023 is we've tried to add a lot more description of why something was taken to caseloads, whether it was maybe you'll see some of them like a physician code rate increase where KDHE, when we implemented that legislative change, we missed some codes in that category. One thing I will say, if you've looked at our KanCare website at some of our rate study comparisons, there are thousands of codes, and this is a pretty manual process, so sometimes we forget a few, and so you'll see things that are related to cleanup. We've also tried to very much indicate when something is an EPSDT, which is a CMS mandate. EPSDT is basically a federal requirement that any medically necessary service to treat or ameliorate a condition for a child has to be authorized. And that means even if it is not in our state plan benefits. So there will be changes made around EPSDT, other CMS mandates. So we have tried to get much better, and we actually present this information to the caseloads group when we present, just so people understand what we're doing and why we're doing it. You'll see a couple items in here. I will point one out. It's the third one down on the first page. It's coverage for diabetes devices. These are tubeless. Typically in the adult population, Medicaid required tubes. What we were finding is for the IDD population, obviously probably due to some very complex medical situations, they were pulling those tubes out. And it was causing, obviously, hardship for the patient and typically needs for stitches or other things, and then it was obviously harming the devices. And so it was an item that we felt for a health and safety reason, there will be some cost offset to that all funds amount. But again, these might be things that come to our attention, typically from the provider or patient community where something that we're doing, a policy decision that we have made creates other unexpected consequences. So again, Happy to answer any questions. You'll see in here too, I'm trying to find one real quick. Of course, when you try to find it quick, you will not. You'll see some references to some CMS changes. We have a program called In Lieu of Services. And what that allows is the MCO can provide a service that isn't traditionally covered by Medicaid and do that saying that if I provide this service, it is going to offset the need for other services. And a great example was sleep machines. So we were covering CPAP machines under the In Lieu of Service benefit program. CMS changed the rules of that program. That was one of the services we could no longer provide under In Lieu of Services. And so the choice for KDHE was either we stop covering CPAP machines, which we felt was obviously going to generate a lot more cost for the program because we know the benefit that they provide. And so we just moved that from an In Lieu of Service over to state plan. So you'll see things like that. So again, happy to answer any questions. Also, as you have time to digest it, any follow-up questions that you have. But you will see as we go back further in time, you will not see all the descriptions. We tried to find as many as we could, but there were just some, obviously predates many of us at KDHE, some of the information we weren't able to find. So again, apologize for that, but I think in the more recent ones, you should have some good explanation of why KDHE brought that forward to caseloads.
Representative Carpenter.
Thank you, Madam Chair. So the first year of the EPSDT, we did $50 million. We had no idea what. So how is that spending going?
I can get you a revised estimate. I haven't looked at it now for about a quarter, but yes, we can pull that data for you and submit that to the committee.
Yeah, I think when I talked to you about it in the
Yes.
legislative session, we'd spent like 30 million of that or something like that.
Yes.
So anyway, just curious
Yep,
about.
I will get you a revised number.
Seeing no other questions, you may continue. Thank you.
If we could go back over to the presentation now, and I will cover some of the other elements. So we're going to see if I can walk and chew gum at the same time, right? Well, maybe. Oh, there it goes. Okay. It just takes a while. Okay, so the first item I'm going to cover today is a detailed comparison chart between KanCare 2.0 and 3.0. Couple intro comments is, and I think you heard this from both Megan as well as our actuaries, by and large, the things that we pay for in Medicaid are policies, rate reimbursements, all of those things that just go year to year. So really in Medicaid, you don't really have the situation where one year you're covering this service and next year that you don't. So when you look at differences between KanCare 2.0 and 3.0, the cost drivers to the program are the same and the services are the same. By and large, in Kansas, our populations are the same. The numbers may fluctuate slightly within that population, but it really isn't anything specific to whether it was 2.0 or 3.0 as far as what the cost to the program are. Because again, our services just continue. It just may be we pay a different rate. You heard us talk in the Bethells leading up to KanCare 3.0 about a lot of changes that we made in the contract. Those weren't really changing services or reimbursement rate. What those were was tightening requirements. So for instance, every member is eligible for non-emergency transportation. What we found is in 2.0, we didn't have a lot of, and I'll call it teeth, in the contract that could let us hold the MCOs accountable. So for instance, that if you have a ride scheduled to go to your doctor's appointment, that ride needs to arrive to pick you up within 15 minutes of the scheduled pickup time. Kind of like you get on Uber, they'll tell you it's going to be 7 minutes. What we found is we didn't have a lot of those requirements spelled out where we as KDHE could hold the MCOs accountable for not only providing the transportation, which is where the cost is, but it allows us to apply liquidated damages if they're making that patient wait for an hour. And really where we saw it the most was the pickup from the appointment. Like their appointment was scheduled to end at 3 o'clock and we'd get complaints that the driver didn't arrive till 4 or 4:30 and that poor patient is sitting there for an hour and a half. So we added a lot of requirements which really didn't impact cost from how much we're paying in capitation to the MCOs, but I think allow us as KDHE to hold the plan much more accountable for the level of service being provided to the members. There are a series I'm going to go through. So in 2.0 and 3.0, we hit one of the exception times when services don't necessarily continue. Most of this is going to be related, I think all of it, to the public health emergency or COVID. So when the public health emergency started, not only did the federal government mandate that we had to keep folks enrolled in Medicaid, so once I approved you as eligible, you would remain on the rolls until the public health emergency ended, but they provided the states a lot of flexibilities. Again, realizing it was a very turbulent time in the program, they were trying to streamline some processes for both the recipients as well as some of the administrative burden on the state. And so a lot of the differences between KanCare 2.0 and 3.0 are the flexibilities that we implemented during the public health emergency that have now since ended. Some of them ended before we transitioned over to 3.0 and some ended just here at the end of June. So again, I won't go through all of these, but you'll see things like some of the things they did during the public health emergency is they allowed the MCOs to have a much more active role in the redetermination process that then was allowed under non-PHE times. Some of those flexibilities have now ended, so the MCO role is much more traditional in support of helping with renewals. Again, some of it was a suspension. They had a suspension of the requirement that individuals apply for other benefits when applying for Medicaid. Again, that has ended. And so again, I won't go through these in detail. Happy to answer any questions. But again, that's really the primary driver or difference between 2.0 and 3.0 is just a lot of these public health emergency flexibilities that the state took advantage of. One thing that I will say that does have a cost component to it, it's really not a difference between 2.0 and 3.0. So in 2.0, we had community care coordination as a program under KanCare 2.0. It was never implemented under 2.0. Lots of reasons for that. It's very complex to implement this program. Our plan is to implement it under KanCare 3.0. We estimate from what we know it will be about $20 million all funds if we implement community care coordination. Like I said, it has not been implemented yet, so it is not in the capitation rates. At the point that we might be ready to implement that, you'll hear Andy talk about it a little bit tomorrow in the KDAD's update. That would add costs to the program if it was implemented. So I do want to point that out. Yes.
Just to be clear, that's just for HCBS waiver, the care coordination.
Well, see, there's a difference. So care coordination is already implemented. So we have in KanCare 3.0 a variety of populations. HCBS is one of them, all of our long-term care members, high-risk pregnant women. There's a series of populations that we require the MCOs to provide care coordination for those members. That is already implemented. That was implemented even in 2.0. Again, we strengthened some requirements around who could provide the care coordination for those populations, but that's really a continuing service. The concept of community care coordination is trying to address some of the whole person. Again, not that Medicaid would pay for these things, but there'd be care coordination that would utilize community health workers or other local resources to identify if they have food insecurities or they need electrical assistance to keep their electricity on. Again, for some of these populations, those can be very, very critical components. So community care coordination is really trying to coordinate, and Andy will do an overview of what it is, but it's different than just regular care coordination. Two different programs, same names. Any other questions?
This community care coordination that you mentioned, is this something that was part of the RFP initially? And there has to be a cost to that.
Yeah, so it was actually a part of the 2.0 RFP as well as 3.0. It was never able to be implemented in 2.0. We have not implemented it under 3.0. We're trying to. It's very complex. I will say there's a lot of difference of opinion of what community care coordination should do, how the model should be structured. Andy will talk about some of that tomorrow. If we were to implement it, we estimate about $20 million.
Thank you.
All funds. Okay. All right, now on to, these are going to be some of the updates from the federal level. So obviously we'll have some late breaking news on some of these. So just kind of more on the administration side, the new administration is making some changes to some of the 1115 demonstration waivers. Kansas does have one small 1115 waiver. I think as a real positive that I would point out is that CMS has created a new oversight process for the 1115 waivers. I will say historically, the oversight was very administratively cumbersome for the states, and this really does seem and appear, we're still just meeting with CMS on how this will all work, but it does look like it's going to reduce some of the administrative burden for the state, so that's a good step in the right direction. Just a couple things that really don't impact Kansas. CMS made changes to the health-related social needs 1115 waiver. Kansas does not have that waiver, so there's no impact. They've also are going to no longer approve designated state health program funding 1115s. Again, that is not 1115 that Kansas ever had, so no impact to the Kansas program. There is a proposed rule on provider tax. This is separate than what happened in the reconciliation bill that the president signed that I'll talk to in a little bit. But this rule that CMS has drafted is targeted at provider tax programs in 7 specific states. Kansas is not one of those, so that rule will not impact Kansas. Their provider taxes were structured very differently, and they weren't uniform was kind of the key element that CMS is looking at directing or changing. The last one, I'm going to wait and talk about that when we actually get to the reconciliation bill because these two items overlap. But in addition to what happened in the reconciliation bill that the president signed that made changes to state-directed payments, CMS also has a proposed rule which would potentially make more changes to that program. So I'll talk about them both together. All right, so here is, and we will have, and we will provide a copy to the committee. We're planning on having a full analysis done of the reconciliation bill by this Friday. I'm going to highlight several things that we already have looked at. One thing I do want to caveat with everything I'm going to say, this is our interpretation. We're working with the National Association of Medicaid Directors and all of our partner Medicaid states, but at the end of the day, it will be CMS's interpretation and CMS guidance that will drive the final say on how these are implemented. So this is our best educated attempt at understanding the language and what it will mean for each of these provisions. So I always want to caveat, some of these I think we're going to be spot on. There's a few, and I'll highlight it, that I think there's probably going to be some differences once CMS comes out with their final interpretation. And again, some of this information, obviously things move very quickly as we were getting ready to submit this, so I may deviate a little bit from the words on the page, but again, trying to give you an idea of some of the major components. I will start with provider tax. Some good news from Kansas in the provider tax is non-expansion states. They kept what they refer to as the safe harbor or the threshold that you can Have your provider taxes under, which is 6%. You heard that discussed earlier. Non-expansion states, our provider tax level can remain at 6%. And so we are still waiting for our 2025 HCAP documents to be approved by CMS. We are not anticipating issues there that will be considered grandfathered per the language. We were also able, I know last session there were some changes made around critical access hospitals and rural emergency hospitals. We were able to get our 2026 preprint submitted to CMS on June 30th. So again, per how we read the legislation and when kind of the cutoff was, which would have been July 4th, the day it was enacted, that should now be considered and grandfathered under the 6%. So we think we're going to accomplish even the changes from last session. Again, we're still getting questions from CMS. So, they may make some modifications, but by and large, our provider tax should be okay. The next one is, this one is the one I'm going to caveat. Where this will end up at the end of the day is one that is to be determined. So there's provisions in there. So we've talked about PERM a little bit at the Bethell Committee. It's really a payment error rate measurement that CMS does every 3 years for states. We just finished a cycle. Kansas historically, in the last 2 PERM cycles, our PERM rates are some of the best in the nation. So again, I will give a shout out to the eligibility team. We do very well compared to a lot of other states. So we're not overly concerned about the changes to the PERM itself. So what the change is that there's going to be restrictions on asking the federal government to waive certain findings. So under the PERM process, there are certain findings that today can be waived, which means you don't owe the federal dollars back. They're going to restrict that. So in just PERM itself, because we perform very well in the last 2 cycles, not overly concerned, but they added this language at the end that the Secretary of HHS can add other audits, state audits, to your PERM error rate. So now it's not just PERM, it could be other audits that could apply where they would want the federal dollars back. It's a very vague statement. I can give you a whole list of audits that we undergo. Is it going to be 2 audits? Is it going to be 10 audits that could be considered in this pool now? So again, all states have concerns over this language and how broad it will be interpreted by CMS. So more to come, but one we're watching very closely. The next one is state-directed payments. This will definitely have an impact to primarily our hospitals. So again, these are payments where I'll do one. We have an uncompensated care pool that our public teaching hospital, KU, and Children's Mercy. It's about a $10 million pocket of money that they can draw down. All of our state-directed payments are at average commercial rate, which is significantly higher than Medicare rate. The way this legislation is written is starting in 2028, non-expansion states every year will have to reduce their state-directed payments by 10%. So starting January 1st, 2028, if they're getting average commercial rate in 2027, that will drop 10%. Then the next year it drops another 10%, and you will do that annually until you hit 110% of Medicare, which, again, we're still looking at the analysis. I can just tell you that Medicare, the difference between Medicare and average commercial is very substantial. So eventually, at the end of the step down, all of our state-directed payments will be capped at 110% of Medicare. I think the silver lining maybe in this is, and you were talking about DISH earlier, these step downs don't start until January 1, 2028. So there's still a window where that provision could be eliminated, or it could be the can could be kicked down the road and they could just keep delaying it. But right now, we do know that especially hospitals who primarily receive these payments, there's some risk there that they would start losing funding under these programs. The next one that will impact Kansas is We have a provision in Medicaid where we call it prior medical, but what it allows is that, and this is really for members, folks applying that are either going into a nursing home or going into a hospital, there's a way that if they're eligible for Medicaid, you can pay for some of those prior medical expenses, which is really one of the only ways that provider's probably going to get paid for that care. Under current program, we can provide prior medical payments 90 days. So let's say their eligibility date was July 1. We could go back to April 1, if my math in my head is correct, and we could pay prior medical for April, May, and June. That has now been reduced to by 30 days. So as this gets implemented, we will only be able to pay for 2 months of that prior medical cost, which means the hospital, the nursing home, that's where we see it most commonly because of the size of the bills. That means that probably 1 month of that, they will not receive reimbursement because it's likely the family, I mean, if the person's eligible for Medicaid, it's likely the family won't be able to pay that. The other provision, one that I didn't have on here that we're looking at, it's one of those areas that I will say I think there's going to be a lot that happens when the interpretation comes out. So currently in Medicaid, if you are here in the country legally, but you are not a citizen, you fall into one of two buckets. You're either in a bucket that your immigration status allows you to be eligible for Medicaid immediately, and there's statuses where you must wait 5 years before you're eligible for Medicaid. So you could meet all other criteria, but by your immigration status, you have a 5-year wait period. The way we read the legislation is they're moving a portion of the population out of the immediately eligible group and into the 5-year wait period group. But they don't list the codes. They just, again, have general language. So we're working with some of our sister states to try to come up with what our best guess is at who's moving. And then we will try to start doing an analysis of the impact because once we determine the who, the second piece we'll have to look at is where in that 5 years are they? Because if they've already been here 5 years or more, it's no impact. So you'll hear things around that. And these, again, we are doing that analysis now to try to determine impact to Kansas. And then the last thing that I will point out is, and again, I think this is very much attributed to our congressional delegation from Kansas. They did create, for our rural hospitals, they allocated a pretty substantial amount of money holistically. Again, we'll wait for guidance to see what the program will entail. We are pretty sure based on Kansas and we're a frontier in a rural state that many of our rural emergency hospitals will qualify, but this will be an application which again will continue to provide some funding to those facilities. So it was an attempt to recognize that with the changes in state-directed payments and not so much for Kansas because we're not an expansion state, but with the provider tax, it was a way to still get money to those facilities. So more to come, but we're watching that closely as CMS will release guidance on what will make up that pool of money. And they did put in the applications will be due by the end of this year. Any questions on the one big beautiful bill?
Yes, Senator Petty.
Thank you, Madam Chair. So let's just start with the one you just left off on. That $10 billion right now, you don't know how many states, how many rural hospitals, and how it will be divided.
Correct.
So, I mean, even though it was a great addition, the reality is lots of hospitals, lots of states, and not very much money, really, when you talk about 50 states. I want to go back to on the part about the Secretary of Health and Human Services, the option about being able to add other audits. I know you don't know, right now there's no idea. I guess my question would be, is there actual, this is open-ended, so that it could be done at any time, is that correct?
That's our read of it, yes. There's no time frame that the secretary must decide by this date which audits are considered. It would also, to me, leave it open that they could change it over time. So again, this is one where we really have to wait on guidance, or the way we read it is the secretary could choose not to include any other audits. I think it truly is, on our read, very open-ended.
So it's one or the other. And I'm sure this is kind of hard to ask or answer, but do you have an idea what an average audit would cost the department? Because, I mean, this is a cost now that states have to incur when and if it would come about.
Yes. So, and again, it can really vary. I would say, from a Kansas perspective, looking at some of our other audits where we didn't owe the dollars back, but there was a finding, you could see dollars, $2 million, some in the hundreds of thousands. Again, we're not a large Medicaid program. You're going to see numbers from other states that are really dramatic, but I would say risk to Kansas probably is going to be in the millions, potential risk. I would say, again, based on our size, maybe 3 to 15 million. I mean, it's hard to project. And again, some of it will depend too, how many of the waivers that they take away that allow states to, so I'll give you good examples. So right now, I determine eligibility, and all the pay stubs get attached but one. Now, the other pay stubs would indicate for you to believe that this person is eligible, but it is true that one pay stub didn't get attached to the case. That is going to be a perm error, because they're going to call that insufficient documentation. So there's a really, I think, a very fair process that happens now that kind of puts some reasonableness into that says, okay, you've got, 2 out of the 4 pay stubs, or, 4 out of the 5. Again, depends on how often they're paid, how many you need. So we're going to assume, because every indication is by all the documentation that's there, this person's eligible, state, we're not going to hold that against you. This removes that waiver option the way we read it. And so I think it puts the state at risk, for additional dollars, if you will, because I guess the threshold now is going to be so much higher.
And that's on the state, but it actually goes back to the recipient as well, that they have to provide.
So we don't do anything to the recipient. The recipient remains enrolled. What they do is, for the period of the audit, so let's say we find a member, one of the pay stubs was missing, they say, under this new rule where that wouldn't be a waiver anymore, they say that person should not have received Medicaid. What they do, because this is a payment error audit, they're going to go and say, how much did you pay in capitation for this member? So back to, Seth's chart, let's say they were a TANF member, which is about $300 a month. Let's say we paid 12 months of capitation at $300. They'd say, what is the federal share of that amount? And that's going to give you a dollar amount, but then they extrapolate it across the whole population. So there's some compounding that happens, and so, because they're going to say whatever error rate you had, we're just going to count that against the whole population, even though we only looked at a subset of cases. So it really puts the state at a disadvantage, because they're making assumptions as well. So it is going to limit, the way we read it, some of those, I almost call it the negotiation period, or putting some reasonableness into the process. So we will be at risk of owing more federal dollars back.
We have several questions waiting. Yes. Representative Ruiz.
Thank you for the presentation. Do you know what, how much uncompensated care is already being provided by our rural hospitals? I heard $1 billion the other day, so I don't know if that's true.
So only numbers we would have access to, I mean, and would be what we receive when we're doing other payments, because some of those do account for some of their uncompensated care. I don't know if it would be all of it. I would say KHA would probably be the better source to get that from, because I think they track it very holistically and almost by hospital.
Thank you.
I just think our number would be incomplete, and I wouldn't want to
Sure.
provide something that's not complete.
Senator Owens?
Thank you, Madam Chair. So talk for a second, if you would, about the state-directed payments and this step down. Help me understand that a little bit more. And do you have an example of a code or, a charge and how that would play out?
Yeah, so what I can do, I can follow up with the committee. I can actually get you what our state-directed payment programs are today. And I'll just use one. I mentioned it earlier. So we have one that is for our large public teaching hospital, which is KU. And then it is Children's Mercy. It's a border city hospital. And, again, these are payments. It's about $10 million in total, but that's based on, so when you do these calculations, you can either use what the average commercial insurance rate is for your state or Medicare. And average commercial is going to be significantly higher because we know commercial pays much higher than Medicare or Medicaid. So it's all calculated off of that average commercial. We can give you an example of how it's calculated. But what we're going to have to do is, so 10 million is based on average commercial. We've got to get down to 110% of Medicare. So that 10 million probably at the end of the day is going to drop, I would say maybe $1 million, maybe even a little bit below. I don't want to, give exact figures, but I do want you to know it's a dramatic drop. And so that will be money being taken away that we won't be paying to these facilities, and these programs now become much smaller in the amount of dollars that it's going to provide to our hospitals. But we have a list of, we don't have a lot, I guess, fortunately for Kansas, we have 5 state-directed payments. We don't have a lot. Some states have a lot more. So that's the good news. But for the facilities that are used to this money and obviously depend on this money, it will definitely be a hit.
Yeah, if you could share that with me,
Yes.
I would appreciate that. I think all of us are, concerned about how it could impact our local hospitals and
Yes.
how that plays out. So thank you very much.
And you said 5? What are
Yes.
the 5?
We have 5 state-directed payment programs.
Okay. And my understanding, and having worked with employer-sponsored health insurance, that when you're saying a lot higher, 110% is more than double what Medicare reimbursement would be. That's what 110% means, right? Because so if you had, I'm okay. You're saying a lot more, but what I'm familiar with is 150% of Medicare. Can you tell us what it is? What is the average?
The way I think folks are interpreting it when they say 110%, it will be the Medicare rate plus 10%.
Plus 10%. So then what I'm familiar with, as I said, was rates that are 150% of Medicare. And so you keep saying it's a lot more than Medicare. Can you give us that average? What is that?
I can get for you what we think an average. So this is going to be different than, so I've talked in committee before of where we have some rates that we pay on a claims basis that the MCO may negotiate with the provider, and it could be even higher than Medicare. That's not impacted. So state-directed payments are just a specific payment based on a specific, it's more of a program, but it's not claims reimbursement. So the fact that, again, we may have rates in Medicaid, and you'll see it in our rate study. We have rates, our base rate in Medicaid is higher than Medicare. Those are not impacted. This is specific to just these 5 state-directed payments.
5 payments, but you're going to get us what you've been paying, which you say is the average
Commercial rate.
commercial rate.
Yep.
You'll get us what that rate is.
Yep.
Thank you. Senator Erickson.
Thank you, Madam Chair. Thank you. You mentioned 2 buckets of immigration status that we have in Medicaid. Can you tell us how many are in each bucket, the immediately eligible and then the 5-year?
I can get you who's immediately eligible. I will see if we can get the 5-year mark, because ours, when we pull the data, it's just going to show all the immigration statuses that are currently enrolled. And I'll see if we can go back and see how many of them were based on the 5-year. I think we can, but we'll get you as much as we can. But I for sure can get you the total number of immigrants that are on our program. And then if I may, I know Senator Erickson, you were asking about illegals. You are correct that Kansas does not have a state-funded program where we pay for folks that don't have a legal immigration status. The one caveat I will put to that is there is a program, and I hate the name of it, but this is what it's called, Emergency Services for Aliens. And what this allows is it's a mandated program. So if a person that's in the country illegally, again, federally they refer to them as aliens, would present to a hospital, then Medicaid can reimburse for the emergency services to the point that the person is stabilized. So then we won't pay for the inpatient stay, we won't pay for anything else, but we can reimburse the hospital from when they present until they get them stabilized. So it's not much in reimbursement because a lot of these folks do end up getting, admitted. And then again, Medicaid, because they're not eligible, doesn't pay. But there is that one program. It was in one of the early versions. I believe it was actually one of the early House versions where they were going to remove that program, but then that got dropped. So there is just that one mandated kind of piece of where Medicaid will pay a hospital for some limited coverage for someone who's not legal.
Thank you. And you said it's not much. Can we get the actual numbers for that?
We can tell you.
Thank you. Thank you, Madam Chair.
Yes, Representative Bryce.
Thank you, Madam Chair. Just a quick question on that. You said stabilized. Is that defined? You mean stabilized
Yeah, there's
medically, or there are a lot of different definitions of stabilized? I was just
yes,
thank you.
it is defined federally and really and I know you're going to know this much more than I am, but really what it means at the point when the crisis or emergent situation is over and they've stabilized them in the ER. Now, that doesn't mean they still don't need inpatient. That's what I mean. We're slicing and dicing some hairs here. So I know from a physician perspective, you might disagree with how narrow the definition is. But yes, there's a federal definition of what's considered to be, stabilized or you're past the crisis or emergent need. And it's very narrow. I can provide that to you, but it is very narrow.
Senator Carpenter. Representative Carpenter.
Yeah.
I'm not sure if that was a demotion or not. Okay. Yeah, exactly. Well, thankfully, everyone's taken my questions, and I appreciate that very much. So this bucket on the state-directed payments, what are we talking total dollars?
Oh boy, total dollars. I will get that to you. Well, one program alone is 10 million. So I mean, they're all we're probably talking again, I'll get you a number, but it's going to be 50, 60 some million in total, probably maybe a little more.
Okay.
Yeah.
That's.
Yeah, it's substantial.
And Senator Erickson had questions about the illegal program and all that, and I had that too, so that was clarified. The other thing I see in here, the last question I have is, so non-expansion states have a 2-month retroactive coverage limit for Medicaid and CHIPS. What would happen to expansion states in?
Theirs was taken down to 30 days.
They were what?
30 days. So if you're a non-expansion state, you can do what we call prior medical for 60 days. If you're an expansion state, you can only pay for 30.
Very good. Thank you.
And one thing, the formula for FMAP remained the same,
Correct.
correct? Very good. Okay. Oh, I'm sorry. Representative Ballard, I need to look down at this end of the table a little bit better. I'm relying on my vice chair.
I'll make a comment. Okay, now when you talk about it, thank you very much, emergency services for aliens, okay, at hospitals until stabilized. Part of that is there's already established law that anyone who admits themselves to a hospital has to be treated.
Correct.
You don't have to keep them in a great position. So stabilize just simply says until you've gotten it under control. So this is nothing new because we have always had to, and I think it probably goes back, I mean, umpteen years because they were not admitting people and they had to go from hospital to hospital and people were dying in the process and everything else. Am I correct?
Correct. That's EMTALA. And I don't remember what, it's something about emergency treatment, but yes, hospitals have the requirement that anybody presents to the emergency room must be seen and treated. And what this will provide is for the population of folks that have an illegal status, it provides an opportunity for the hospital to get at least some level of reimbursement for stabilizing that patient, because otherwise that would have been fully uncompensated care. There's still many populations that present that they have to serve that Medicaid isn't going to pay. You know, if you're underinsured, not insured, and you could be here legally, Medicaid obviously isn't going to pay for anything, but this allows for this population at least some Medicaid dollars to be provided to the facility.
Okay, is the 90-10 reimbursement rate for expanded states, is that still in place?
Yes.
Did I hear a no over here or yes? Oh, for now. Okay.
But I didn't cover some of the other provisions, and we can put that in our analysis if you like, but there were some requirements that were expansion states only. Work requirements only apply, well, it applies to expansion states or what they call minimum essential coverage states, which is not Kansas. There's more frequent eligibility checks. Those were for expansion states, and there's some penalties if they don't comply. So there are some provisions in the bill that was signed that would apply only to expansion states.
Madam Chair, may I ask you a question? I was looking at our agenda, and I don't know if we'll discuss it, but at one point, we should discuss, you know, when we start talking about, well, I'll say immigrants, they are working and contributing to Social Security and everything else. That money is, where does that money go? I'd like us to know, for those people that are actually working, they're deducting something from them, but they will never receive that money because they're not legal. So we don't have to do it now, but I think that has a little bearing on, there's a lot more money that's being contributed that we're not talking about.
Thank you. We will put a pin in that. Thank you very much. Thank you for your presentation, and you can continue.
Yep. The next slide is one that I showed before. This is really just kind of a look at what happened during the public health emergency. For, I think most here remember that we received a 6.2% enhanced FMAP. That was really the federal government trying to account for the fact that we could not disenroll folks from Medicaid. So all Medicaid states were carrying a higher caseload of members, and so they provided a 6.2% bump that was phased out over about a 6-month period in 2023. Trying to get my years right. But this was really just a look at, we just wanted to provide a chart that kind of showed year over year the dollars that came into Kansas as a result of that bump to the FMAP. And so what that meant is that was money that we didn't have to take out of the state general funds in order to pay for Medicaid. So you can kind of see it year over year. Obviously, that last full fiscal year of the PHE, we were up, you know, $303 million. So again, it really did help the state pay for some of those costs of carrying that population. And then I think this is my, gotta look, yes, my last slide. This is just follow up on some of our previous conversations around the doula coverage. So right now we have paid just a little over $5,000. We've had 35 claims, only 16 providers enrolled. I did point out some things here of lessons learned that we've had going through this process is non-traditional providers who are not used to interacting with an insurance company are very unfamiliar with enrollment processes, all the documentation that's required to go through the Medicaid enrollment process, as well as submitting claims. So we've had to do a lot of education, walking them through the process. So it's been a lot, compared to, again, what we would call a traditional provider, a lot more work to get them through the process. We're also identifying that some traditional providers are reluctant to work with doulas and other non-traditional providers. Again, maybe just they've never had that experience of having a doula, attending a prenatal visit, or wanting to be in the labor and delivery room. And then we also have many areas of our state that are still a doula desert. That's one thing, the TMAW grant that I've mentioned before in here, that's one of the tenets of that grant is trying to increase both traditional and non-traditional provider coverage in some of our desert areas, which in Kansas, we have many, unfortunately. So again, really doula coverage, very limited right now in the amount of claims that we've paid. And with that, that is the end of my presentation, unless there's questions.
Thank you very much.
Thank you.
And next we will go to Andy, Deputy Secretary for Programs, and I'm sure he'll introduce himself.
All right. Thank you, Senator. And Chair, let me go ahead and start by introducing myself. I'm Andy Brown. I'm the Deputy Secretary for Programs at KDADS. And I'm here today to talk to you a little bit about the KanCare 2.0 and 3.0 changes to the HCBS waivers, and a little bit about the budget in our Programs Department. I'm not sure if there's a good place for me to point this at to make it work. All right. Okay. All right, so this first slide just kind of goes over the differences between 2.0 and 3.0 with regards to the HCBS waivers. And really, we have the same 7 HCBS waivers. We are looking at additional consideration around those community supports waiver for the lower needs IDD members. But that would be the most significant difference between this contract and the previous contract. We also are using the updated term care coordination rather than service coordination. And we're trying to focus on additional details around things like real-time reporting, social determinants of health tracking, and multiple appendices for care coordination and data. And the goal there really is to try to provide a better overall experience and more oversight for the state as part of our HCBS CAP that we're working on. So then in our caseload overview, KDAD's KanCare versus KDAD's non-KanCare. Examples of things that are in caseload, we have our KDAD's Medicaid programs, our nursing facilities, PRTFs, health and substance use services, and then our HCBS SED waiver. It does not include the other 6 HCBS waivers. And then you can see down there, there's also the total all funds that are approved for 2026 in caseload. and the amount for the state general fund share. And then on our KDA's non-KanCare, examples of those that are in caseload are our nursing facilities for mental health, our PACE program, the HCBS functional assessments, and our state hospital screens. And again, you'll see the all funds amount as well as the state general fund portion. Okay, so on slide 6, this is the HCBS waivers budget. And you can see we gave you a little bit of a trend here that goes back to 2020 actuals, just to look at our total cost by waiver. So we've got our physical disability waiver at the top there, followed by the brain injury waiver, technical assistance waiver, our IDD waiver, then the autism waiver, and our frail and elderly waiver, and then ends with our SED waiver. And again, that SED waiver amount is part of our consensus caseload. The other 6 HCBS programs are all funded with direct legislative appropriation. So you can see for the fiscal year 25 year to date, we're seeing increases in a significant number of the waivers. That's largely due to additions that have been added to the waivers in terms of the number of people that are eligible to be on the waiver. And then for slide 7, we have our major KanCare budget adjustments. So these are reflective, again, of oftentimes things that are happening within the legislature, but we've expanded our scope for brain injury waiver to include the acquired brain injuries. So with population growth and some rate increases, that's increased by 25.7 million all funds, including 9.9 million in SGF since fiscal year 20. Our certified community behavioral health clinics, we've had a budget adjustment of approximately 250 million all funds through fiscal year 25 related to that change. Our nursing facilities are at our approximately 200 million all funds increase from fiscal year 23 through fiscal year 26. This again is largely due to rebasing of rates and that Medicaid add-on that you heard about earlier. And then we have additional slots for the IDD waiver. We added 500 slots in fiscal year 25 and another 200 slots for this year in fiscal year 26. And that's increasing by 14 million this year, all funds. And then we have additional slots for the PD waiver. So last year we added 500 slots for that as well, which resulted in an 11 million increase. And then our rate increases for the IDD provider rates, TCM, the BI provider rates, specialized Medicare, and HCBS personalized care services, et cetera. Those have all added to the overall KanCare budget. So on slide 8, you can see that the HCBS waiver renewal dates. So these are just the dates that we're required to renew the waiver with CMS. We're currently working our way through our HCBS cap in order to make sure that we're in a good position to be able to apply for these and continue forward with them. You can see that the 2 that are coming up the soonest are our autism waiver and our serious emotional disturbance waiver for children.
Andy, before you move on, I was looking through the presentation when it was put online earlier, and I didn't see anywhere where you're addressing what we've been working on for, 3 years now, the community-based waiver. Where are we on that?
So right now, we are in the process of trying to make sure that we have our HCBS cap being addressed so that when we apply for that waiver, we have a pretty solid understanding from CMS that they'll be willing to approve it. So we have to make sure that we have things like conflict-free case management resolved before we move forward with that. All in all, I think we are fairly well positioned to accomplish that. but it may require us to come back and just verify with LCC that we're moving in the direction that they want us to.
So what sort of an estimated timeline are we looking at?
So that, I'm not sure that I can give you an estimated timeline for when we would have approval from CMS to enact the waiver.
I guess to where we feel like we're ready to have it totally submitted, because it's not actually submitted yet, right?
That's correct.
So how, I'm asking for a timeline as to when we could submit, not when they would approve.
I'd have to go back and get an estimate on that. I don't have
Would
one
really
today.
appreciate that. Thank you.
Yep.
Please continue.
Okay, so this is the waiver population update. So looking at the slide on page 10, this shows you by HCBS program waiver the number of people that are eligible to receive those services, as well as on the IDD and the PD waiver, what the wait list numbers are. And this is as of June. And then for our wait list history, on the IDD waiver here, again, you can see roughly a 5-year, 6-year trend on how we're doing with regards to the wait list. And you can see right now, our estimate going into this fiscal year is that we're at about 4,482. We're currently on a wait list cap for the IDD waiver. So those of you that are familiar with that, we are required to maintain the waiting list not more, or in other words, below 4,000 eligible individuals for fiscal years 26 and 27. So right now, we believe that we're exceeding that cap by about 482 individuals. And the cost for an additional 482 slots would be about 33.5 million all funds, which would be 13.1 million SGF to stay below the cap this year.
Andy, I'm going to stop you again. Could you get for us, if the community-based waiver was approved, how many of these slots would go down? Can you find that out for us, please?
Yeah, I'm happy to try to give you an estimate on that.
Thank you.
Again, I think the best we'll be able to do is an estimate.
Should say people on the waiting list, how that list would go down. Thanks.
Okay, so on the next slide, page 13, this shows the census projections for the IDD waiver. And again, you can see here that over the last couple of years, we've had significant growth in the caseload. And that's a reflection of the additional slots that have been added to the program. And on page 14, we'll switch over and start talking about the PD waiver. So this is the waitlist history on the PD waiver. Again, you can see that there's been a significant reduction there based on the addition of 500 slots last year. We also have a waitlist cap on the PD waiver. Here, however, we're not projecting that the physical disability waiver waiting list will exceed the cap. So we're in good shape on that one. And then the census projections for the physical disability waiver. Again, you can see we've had a significant increase there related to those additional 500 slots. And then moving on to page 17, this is our autism waiver. Here you can see this is our proposed recipient list history. So these are the number of people that would potentially be eligible for the waiver. Then on page 18, this is our census projections. So here you can see we had a little bit of a dip last year. We're expecting that to go back up. And then for the autism funding summary, you can see there that we've also had a dip in the overall costs. And we think that's related to demand for services and a change in the way that those services are applied to the state plan versus the waiver services.
Representative Carpenter.
So, Andy, thank you for being here. So on this, the waiver slots, you estimated it's 13 million SGF to stay below the cap. And we've appropriated 14 million all funds, 5.4 million. So you really don't need 13 million. Is that correct? Is that, you see what I'm saying? You're saying it's 13
You're talking about the 250 slots that were added for this year?
Right.
Yeah, so I do think that when we start making those wait list offers, that will reduce the number of people that are on the wait list. But I do think like we are estimating that there may be periods of time during the year that we are above that cap. And so I think that's something that we're talking about looking to go to caseload with later. Or sorry, not caseload.
Yeah, I get that, but you could actually subtract $5.4 million off of this 13.1 million. We've appropriated 5.4 million. Is that correct? For 200 slots?
We do have funding for an additional 200 slots.
Okay, and you're saying,
That will take off more than 200 people as we're offering slots. There'll be additional folks that.
because they won't accept them.
Right.
Because they're not either non-existent or whatever.
Yep.
Okay. Just want to be sure you don't need $13 million. You need, we've already appropriated 5 million.
Yeah, right now we're over the cap. And so we're wanting to make it clear that like we're not below the cap at this time.
Right. Thank you.
Representative Ballard.
So if they're eligible to receive, that means they're on the yep. Okay. So on the brain injury waiver, here you have the census projections. And again, you can see here that we have a diversion in the lines here from where we have our request that we had for additional appropriation last year versus what was actually allocated by the legislature. So right now, we're anticipating that there might be a potential need for a wait list for the BI waiver. We're currently working with providers and stakeholders to try to see if there's a way that we can address that and mitigate the need for that. And so we're not, I don't think we're ready to make an estimate on what that would look like, but this is based on the funding that we were allocated last year. And then similarly, on the frail and elderly waiver, we also provided a deviation in the lines there between what was requested versus what was received. And then the last one is the TA waiver. And again, you'll see a diversion in the lines there between what we requested last year and what we received. And then for the HCBS, estimated shortfall. So this is our current appropriation versus our estimate and what we think that shortfall might be. So right now, for the FE waiver and the BI waiver for fiscal year 26, you can see we're estimating a shortfall of about 30 million all funds. And then we have for fiscal year 27, for the 3 waivers, including TA, an estimated shortfall all funds of nearly 90 million. And then on page 23, this is the census projections for the SED waiver. And you can see here that our estimates are holding steady at about 4,000, with our actuals year-to-date being 3,900. And then this is the waiver that's actually funded in caseload. Any questions?
Representative Carpenter.
Thank you, Madam Chair. So Andy, I thought, was it last year that we increased, or is it going to be in effect this year? We increased the hourly rate for the frail and elderly waiver. Does that take effect now in 2026 then?
Brad, do you know the answer to that one?
And I heard some talk about that, and I remember that we increased it to $30. Is that not in this budget?
Brad Ridley, CFO for KDADS. And I think that was last year, Representative, that was increased fiscal year 25, if not fiscal year 24.
Okay. I was looking through here to try to find that. Thank you.
Andy, I have a question back on page 7 that I have marked. I remember when we instituted the CCBHCs that it was supposed to be saving money, and I'm trying to understand the 250 million all funds through federal year 25. Is that an increase?
So the increase is based on the cost of providing the additional services. So when you look at how costs are measured for the CCBHCs, I don't think there's anything in that amount that offsets costs in other areas, which is where we expect to see savings. So when we're providing services in the community, we're expecting to see savings in institutions and institutional level of care. So we're talking about things like reduced hospitalizations, those kinds of things, and those savings would show up on other cost lines.
And it would be hard to prove a negative, wouldn't it?
Yes.
Because they went there, then we know they wouldn't go there. So then, but we should see an overall decrease in cost at the institutions. Have we seen that?
I would have to go and get additional data.
Would you please, Andy?
Yep.
Thank you. Additional questions, committee? Yes.
Thank you, Madam Chair. Going back to page 13, I'm looking at the FY 26, or I guess maybe even FY 27, increases in the estimated number of people in the HCBS IDD caseload summary. I mean, when I see the graph going up like that, this is kind of depressing, and it feels like whack-a-mole that we're not making any progress. Is there any, what's the rationale behind, I think with,
More people put on.
right, I know it is, that's an estimate, so what's driving that estimate, that increase, I guess, in the estimate?
I think maybe the easiest way to answer that is that we're anticipating an increase in the number of people that would be potentially eligible, right? So that then drives additional numbers for the wait list, And if we're looking at the additional increase in services, that's based almost entirely on the addition of additional slots within the program.
So maybe the question is, why do you anticipate that? I understand you can anticipate that, but why?
Well, we've seen sort of nationwide over the last 20 years, a significant increase in the number of people that have had diagnosis that would be qualifying for these waivers. That's something that I think is just a nationwide sort of phenomenon, right? Like we're more aware as a society of what to look for in order to diagnose people, and we maybe have a better system of screening and diagnosis in place that's allowing for additional people to be identified for treatment and care.
Thank you, Madam Chair.
Additional questions, committee? Seeing none, thank you, Andy, very much for your presentation. Committee, we will go next to the KDHE overview. Oh. Scott, I completely passed over you. Please forgive me. Welcome to committee.
Madam Chair, I absolutely will. Or I can let KDHE go. I'm happy to do that as well. But you did ask for an update on state hospitals in our budget history over the last few years, so I'd be happy to do that. I'm Scott Bruner. I'm the Deputy Secretary at KDADS for Hospitals and Facilities. Continuing in the presentation that Andy was working from. Oops. Okay, so I approached this kind of in the reverse order that Andy did. Andy talked about the budget history for the waivers and then some of the policy initiatives that were in place. I went the reverse direction and tried to pull out some over the last 2 or 3, 4 fiscal years, significant things that were added or contributed to the state hospital budgets that I wanted to highlight, and mostly to appreciate the work that you all have done to really invest in the state hospital system. So on this slide 26, just highlighted a few things. One, that we're very appreciative of our base pay increases in 24/7 facility incentives over the last several fiscal years. Working with the governor and working with all of you, we've made a significant improvement in the base pay rates for direct care staff at the hospitals and done that first through incentives around for facilities that operate on a 24/7 basis, and then we've rolled those into the base pay, so that helps us keep the progress that we've made. In 2023, you invested in us adding a secure behavior unit at Parsons State Hospital for individuals with intellectual and developmental disabilities that are in community placements but have some severe behavior or disruption that maybe gets them involved with law enforcement or into an acute hospital setting, and where they really needed some intensive time spent with their IDD and some behavioral therapy that we can do. In 2023, I showed you the investment there of money and positions. We renovated some space. It took us a couple of years to get the positions recruited and hired, and then we had some additional training that we wanted to provide, but we have opened that unit. It's been open for about a month and a half. We've admitted two residents to that location out of the 3 beds that we've got available, and we're kind of still evaluating the impact of that as we go forward, but that is a significant investment to the system to address people that have severe behaviors along with their intellectual and developmental disabilities. You also invested in our outreach program at Parsons. That's some staff that we have that are extremely highly skilled and trained in behavior therapeutics. They work from the Parsons campus, but they live all over the state. They support community providers that, again, working with individuals where maybe the direct care staff needs some additional skill enhancement or some different approaches. And we've added some folks to that team with the investment that you all made. For contract staffing, we've talked about this a lot with those of you that are on budget committees and in the Bethell committee as well. We're going to talk some more about it actually here in just a couple of minutes, but that's been a significant investment that you all have made that let us keep the bed capacity open and use labor that we don't like it. We don't like hiring contract nursing staff, but that has helped us maintain capacity over the last several years. You've invested in some security enhancements at Larned. We had a significant audit of our security presence and profile, identified some things around fencing and alerting and video cameras, and some staffing related things that we put into a budget enhancement in fiscal '23. And we've completed all of those where there was a capital project, but significantly improved our security presence. And then finally, we added some treatment staff at Osawatomie State Hospital in 2023 as we were coming out of the our moratorium on admissions and opening a new building. You invested in those staff, and again, our Bethell remodel is complete and open. But again, just wanted to highlight a few of those particular items. And then what we did was put together some tables of kind of the 5-year budget history or 6-year budget history for the hospitals that, based on what your request was back to 2020, shows, again, you've got a slide like this for each hospital with the total budget amount broken down by our major categories of expenditures. What you can see from all of those, all 4 of these tables, which I won't spend probably much more time than this talking about any of them, is that most of what we spend at the state hospitals is on salaries and wages. We invest in our people, and our people are the ones that are providing the services. Contractual services is next. Contract labor is a lot of that, but we also have, with the number of patients that we serve, supplies and equipment, contract for other kinds of services that we don't provide directly on campus. But when you're spending money at the state hospitals, you're investing in the people that work there. So on each of the slides, we also captured the number of positions that were funded based on what was reported in the actual in the governor's budget as actuals, and also the census of patients or residents at each of the hospitals, so you can kind of get a sense of the number of people that are being served. I'm happy to answer any questions about individual ones of those, but the information is the same for all.
Representative Carpenter.
Thank you, Madam Chair. Scott, thanks for being here. Could you break down, and we'll need this, we have some interim days on the state hospital, but the actual contract labor in contract services, I think, well, I'm looking at Larner, and it's 54 million, and I think it was 43 million.
Got that on
in actual contract,
yes,
labor. So could you break that down for each of those hospitals for us so that we'll know what is contractual services and what's contracted labor? That would be a better breakout for, at least for myself, so.
I've actually got that on a later slide.
Oh, you do? Okay,
yeah.
well then never mind.
But there are some other, just for the contract nursing, we do have other, we do hire locums physicians to do coverage. We have a dental contract, and so there are some other types of labor that we pay for, but.
Glenn, I apologize.
No, not at all.
In here earlier, but I'd like those numbers. Thank you.
So I'm going to scroll through those, and again, if you have.
Before you move on, let's see if there are any additional questions. I do have one for you. So at the bottom of the page for each of the hospitals that you have this for, it says census, so that's telling me that's the number of people that are being served,
Yes.
correct? Okay, so we've gone from 144 to 129, say for Osawatomie, for example.
Yes.
So then, but when it shows positions, we went from 46.5 to 530.
Nope, that's a great question. So we did add some positions to bring our staffing level up to what was required as we came out of the moratorium that was, and to keep our CMS certification. So we've done that. It's supplementing the staffing for the level of acuity of the patients that we're serving. The census is down a bit when we renovated our Bethell building. That dropped the number of acute beds that we had from 60 to 42. The 60 were in 2 buildings that each had 30-bed wings. Those were dual occupancy, so they were 2 people to a room. With the level of acuity of patients that we were seeing actually in this time frame, we were rarely able to keep 2 people in a room together. It wasn't safe for them, wasn't safe for the staff. So we were keeping those 60 beds at about 42, 45 of capacity. So when we remodeled the Bethell building, every patient has their own room. So we have 42 rooms and 42 patients, but those are full almost all the time. So our ratio is is higher, our occupancy ratio is higher, but the total number of beds that are available and patients we're serving is lower. But we're turning those every 14 to 16 days. So the census at any one time is a little lower, but our total throughput is higher than it was in 2023.
So just doing the basic math, in 2020, we had 3.38 staff members to occupant. And then in 2025, it's 4.11 per occupant. Okay, thank you very much.
I'll take your word. I didn't do the math, but that's a great way to look at it. I'll take your word for that. You got it that correct.
All right. Representative Ruiz.
Thank you for the presentation, Scott. What's the current wait time for a bed at, let's say, Osawatomie? Or how many people are waiting, I guess. That's what I really want to know.
Those are two separate questions,
Yes.
but both very good. Today, I think the wait list was about 32. For our June monthly report, we reported a wait list of 36. That would have been on the last day of June. But we've been hovering around 30 to 35 the last couple of months. And you asked about wait time. The average length, the average wait time for Osawatomie for the acute side was about 91 hours in June. Not about 91, it was 91 hours.
Thank you.
And again, as you look at that or have questions about an individual hospital, happy to talk about that, or you can certainly reach out and happy to talk to you later. Those are the 4 hospitals.
And we have one more.
Oh, I'm sorry.
Representative Sutton.
Thank you, Madam Chair. Scott, maybe you can, I don't know, help me complete this picture here a little bit. When contractual services, I'm looking at Osawatomie, I haven't gotten to the next page yet, but contractual services is tripled. And I would assume that that has to do with contract nursing and staff, and I get that. But at the same time, salaries and wages have gone up like 25%. I would have expected to see a decrease in salary and wages as we hired or supplanted it with contractual labor. Can you help me figure out what's going on there?
Again, you're exactly right. The spending on contractual services itself is almost entirely related to contract labor and nursing. Our salary and wage line of what we actually spent, so this is money that we spent that was paid to employees. That's gone up over time because we've added to the base pay rate with the 24/7 incentives and then rolled that into the pay plan. Where there is some swap that you don't see on this table is in the budget process, we budget a line called shrinkage. So that's the difference between if we took all of our positions and funded them as though somebody was in that position, and then figure out how much we save because that position isn't full or isn't filled, and then we report then the net. So this is more reflective of, I think, our budgeted salary. I will get it wrong if I guess, but is 20 to 25% higher than this when we talk about filling all the positions or having all the positions filled. Our shrinkage rate that we generate is somewhere around 25 to 27, 28%. So you're not seeing that differential here. When you look at it in the budget, in budget review, you get both of those numbers, our total filled head count and the shrinkage amount to get to this net.
Right. When we're looking at it in the budget, though, I generally don't see the very much of the contractual labor being reflected as anything other than just a number. So I don't have the numbers of people that we're talking about here. And I'd like to get that to see, to get a more accurate picture of what's actually happening. How much of the staff is contract labor? And if so, if it's a significant number, why are salaries and wages going up? Thank you, Madam Chair.
Representative Carpenter.
Representative Sutton, I can kind of elaborate too, is we've been in this mode to try to decrease contract labor. So we've been raising the wages. Unfortunately, it hasn't really helped that much. I mean, we've put a ton of money in wages at Larned, Osawatomie, raising the wages up to try to keep permanent employees. Someone else could elaborate a little bit more than me, but it's been very disappointing at best with our vacancy rates and still pumping millions of dollars into increased wages, and we still have to hire contract staff. Very disappointing.
Additional questions? Representative Ruiz.
I'm just going to add to what Representative Carpenter said. We have been working really hard to raise these salaries, and it is disappointing. But the stories behind, being able to attract folks to work in Larned, that's where it really shows how difficult it has been to keep and attract people to go and work there at the Larned State Hospital. And we've looked at bumping salaries for them ongoing, and yeah, it's hard to see the contractual services just keeping up there too.
I have a question. Could you explain to us the definition of commodities?
Consumable products that we purchase, so medical supplies, food, fuel, things that are consumed.
That's what I thought, but it looks like that's doubled. So is it just the costs have gone way up? Because again, we have fewer people.
Well, the census on any given day, it doesn't reflect the throughput. So as we have those, anyway, but costs are higher too. I can probably rely on that. There's higher cost for fuel, for some food, for medical supplies. There was a lot of COVID spending around in commodities too, for masks and other kinds of products that we needed for infection control.
Thank you. Please continue, Scott. Oh, I'm sorry, Representative Ballard.
That's right, thank you. And I'm going to add to that. If we go back, our problem before was overtime pay. And it was exorbitant. I mean, it was just huge. So then part of, with the overtime, we then, and there was a bigger problem because employees were leaving because they were exhausted. They couldn't take care of their child care. They drove a long distance because they couldn't find housing, and it went on. So now, but when we look at this, the contract nursing, of course, is based on what that particular person is charging. It doesn't mean that that individual is getting that amount, but maybe their boss or whoever owns this thing. But is it also, we try to cut back on contract nursing. So now we're going back a little bit with employees working overtime, where before they dropped, now they're increasing up because they're cheaper than to do the nursing. So how are we planning to balance that?
That's a very insightful question. And you've all asked, for those of you that have asked questions, very insightful questions about the dynamic. So it's true. Well, I think what we've observed, and when the superintendents have come up to talk to you about contract labor, one of the observations they made was that it does seem like our staff are mandated less, so where we have a hole in the schedule and we require somebody to stay and work because we can't leave that spot open. That mandating is reduced, and contract labor helps with that because we can pay the contractor to work that shift as opposed to holding one of our own staff over. And then the staff get more control over their schedule and when they work. They work a lot of overtime. choose to work a lot of overtime, and they get to choose more of when that overtime falls. So in terms of the balance of work life and childcare and all the things that you mentioned, Representative, the fact that employees are getting to choose more of that overtime schedule makes a big difference. The other thing that we've been trying to do in managing the spend between contracts and our staff are, we were using contract labor for a lot of overtime as well, and we've severely limited that. So we're still paying at least twice what our staff would get per hour, but we've, I think, almost entirely stopped paying, except in very rare circumstances, a contract nurse time and a half. So couldn't do the division. I'm not even going to try to do the multiplication. So we've reduced that quite a bit. So it is a balance. It is something we're trying to maintain and think very deliberately about. We've frozen the hourly rate that we'll pay for contract labor because we had lots of choices, and we've frozen it at $90 an hour. We won't pay anybody else any contractor more than that at Larned. So we've looked at all those kind of levers and figured out which ones we can pull, which ones make a difference, and hopefully I can convince Representative Carpenter we are making some progress on 3 of the 4 campuses, but the dynamic is exactly the way you stated it, and it's complicated.
The only thing, Madam Chair, I would add to that is that on top of all of that, you have to make sure that you're following the guidelines of CMS.
Mm-hmm.
And so when you put that there, then that says you either have to decrease or increase according to what CMS, and if we want to be certified, we don't have a choice because the difference between licensed beds and certified beds, and we don't have enough of whatever we need at any given time. So I think it's a dilemma, and I would say it does cost a lot, and you can't put it down on paper why it costs that much because you don't know how much contract labor it is going to be at the office. But yet, it's better for the employee. We're keeping them longer because they're choosing, as he said, to work overtime, where before they didn't have a choice. We said, you'll have to make some arrangements or we're out of compliance. So I think it's a good question, I think, to ask, but I don't know what the answer is to it because we're responsible for the individuals that are using that service.
I think one of the things I'm proud of is that other than Osawatomie, we haven't closed any beds. We've kept our capacity the same since all the way through COVID, since I started in this role. And that's been a real challenge to do, but we've made that commitment that we're going to keep beds open so that we can keep serving people, not create unnecessary delays. I'm going to talk some more about that too later in the presentation. But I feel really proud of that as a goal because we could have come back to all of you and said, we're not going to have 72 beds at Larned for care and treatment cases for the western 2/3 of the state. We're got to go to 65 and then have impacts from that. So I guess it's one set of problems or another set of problems, but we're again, and I appreciate the questions about how we're managing it because it's a very active process.
Representative Carpenter.
But we did close beds at Larned.
Before this time period.
Okay. I'm just curious
Since,
what time. Okay.
Right, one time, well, not one time, but we did go down to 72 and we've stayed there.
Staffing level. Right.
Yes.
Okay, just wanted to be clear.
I'm curious, so we have salaries and wages, but what about benefits? Do the employees of the hospitals get their benefits through the state plan?
They do, and that's in that salary and wage number.
That is included, the benefits are included.
The total
I was just
cost of
curious, as we know that the contractual services, majority of them get their services through the employer, through their employer, as opposed to here. So it is, so it is apples and apples. That's what I was wanting to know.
It would be on different lines of this
So
chart,
if the
but
salaries and wages includes benefits, that was why I had that question, knowing that contractual services includes benefits as well, because it's just the payment that you make to that employer on their behalf.
That's correct.
Okay. Thank you. Additional questions, committee? Yes, Representative Bryce.
Thank you, Madam Chair. Just a quick question. The average length of stay, has it been pretty stable or becoming longer or shorter, would you say, over time in most of these facilities?
It's been fairly stable at Osawatomie on the acute side. It ranges, it's between 14 and 17 days. Larned's a little bit longer. It's more in the 20 days range, but we haven't seen a significant increase in the average length of stay.
That's good. Thank you.
Seeing no additional questions, Scott, thank you. Please continue.
Hopefully answer some of the questions here with additional slides. I did want to spend a minute just talking about our fifth state hospital that's in construction, the South Central Regional Mental Health Hospital. We're working on adding this capacity. It's a 104-bed hospital in South Wichita. We can talk more about that if you have questions, but I did want to show the history of the financing. This doesn't show up in the hospital's budget. It shows up in the KDAD's budget, but we're going to be shifting that over the course of this budget cycle. So from what the direction in 2023 to build another hospital to serve a region of the state was with a $15 million appropriation that happened in 2023 and every fiscal year since then. In 2024, the legislature added $26.5 million to let us build, instead of a 50-bed hospital, to double the size that was being proposed. As we've gone through the design process and laid out the rooms and wings, it'll be 104 beds in total, but that $26.5 million let us go to that larger size. And then there's $25 million in Spark funding that's part of that project as well. What to expect over the next couple of years, we'll have a separate budget for that hospital. In the legislature passed last year a bill to create the state agency for the South Central Regional Mental Health Hospital, which gives us lets us set up an accounting structure and personnel structure, and so we'll see that roll out over the next couple of years. In 2026, we'll have some partial year funding for positions related just to the South Central Hospital. And then for fiscal 27, our plan is to give you a full budget it'll be a partial year's budget for full operations because we're planning to open in January of 2027, but you'll get to see the fuller picture of what that hospital will look like in terms of staffing and other costs. So let me transition a little bit to talk some more about contract staffing, and we've already mentioned a couple of these things. Again, to give you a little bit of context, as of the end of June, or the last pay period in June, we're showing you the turnover rates for all four of the hospitals: Osawatomie, Larned, KNI, and Parsons. That is the number of positions that are of people that leave. So that turnover rate and it should have given you something to compare it to, but at the height of COVID, those rates were all in the 20 to 25%. So we've significantly reduced, we think, our turnover rate. The vacancy rate for all positions, this is for related to the total number that was on the budget charts, is about 32% at Osawatomie, around 35% at Larned, 22% at Parsons, and a little under 10% at KNI. Again, that's all positions. Those numbers are significantly better than they have been. That does look at all positions on the campus. Over the last, I don't know how long it's been actually, but the Bethell committee's asked for kind of the history of this over time. So I've produced charts like this that shows the number of vacancies by hospital back to 2021. So before COVID and some of the salary incentives that you all implemented. This isn't all positions. This is just the direct care positions. So our mental health and developmental disability technician positions, nursing, and safety and security, those kind of key positions that are involved in patient care. Again, this starts in 2021 and goes forward. The top line is Larned, of course, because it's the largest of the hospitals. But so where this ended in June, there were 260 vacant positions in those classes of mental health, disability techs, nursing, safety, and security. The line, the orange line that's drawn on there is when the 24/7 pay plan incentives went into effect. And we've seen at least some leveling of that leveling of the increase in the number of vacancies. Larned has actually crept down a bit. KNI's seen a pretty significant drop in vacancies. It's a little more telling when you look at it in terms of percentages. So Larned still has 46.5% vacant in those kind of key staffing, those key direct care staff positions, but that is down from the peak. Osawatomie's made a lot of progress. The bottom line is KNI, KNI, and it's made a significant amount of progress as well in terms of filling those kind of key positions. For Representative Carpenter's benefit, and others, all of you have certainly, is our contract staffing expenses back to 2019 for Larned and Osawatomie. Again, maybe just to call out, Parsons State Hospital doesn't use contract labor, hasn't through the pandemic, and KNI's use is larger than it was, but not on par with the numbers that were presented here. So for Larned, our estimate at the end of 2025, because we put this together before the fiscal year closed, that we spent $44.9 million on about 232 contract nurses, LPNs, or CNAs on the Larned campus. I don't think the number is going to be significantly different from that when the fiscal year actually closed out. That's stayed relative to, talk about Osawatomie first. At Osawatomie, their estimate for the end of the year was about $15.2 million for about 105, again, nurses, LPNs, or they don't use CNAs, but nurses or LPNs. So Osawatomie has seen some reduction. They've been really deliberate about where they put contract labor, how it's being used. They've actually had some success in converting agency nurses to state staff, which we've talked about in different contexts before, that we didn't think that would happen, but I think I think over the last year they had maybe 5 or 6 that wasn't just pay, it was also work environment, the ability to flex their schedule or be a little more selective about how they design their schedule. So some of those things have worked, and we're trying to figure out which of those things would work in the Larned context. Just the scale's much larger. The legislature last year added funding for contracts labor for Larned and Osawatomie, and but they did not add anything in fiscal year 2026. So the other decision that we've made over the last several years is to only ask for what we need in the fiscal year that we need it. So we put together a budget enhancement for the future year based on our projection, but we've been funding really from year to year. So again, just to give you some context about the number of staff and the total amount of spend. Related to contract staffing, there been over the last couple of years, you've given us some authority to do bonuses in a different way than we've been able to for state employees. We had a proviso in 2024 that gave just the state hospitals the flexibility to go up to $10,000 per employee and use bonuses for different things. Last session, the House passed a bill that was introduced to kind of to put that flexibility in statute. And there was a proviso in last year's budget bill that continues the work that we were doing and expands it to all other state agencies as well. On the next couple of slides are the bonuses that we've been paying. We work with the Department of Personnel Services to identify how to pay these out, how to track the expenses, and the number of bonuses that we've done. So we have done a sign-on and referral bonus. So if you start as a state hospital employee, after you've been employed with us for 90 days, you can get a $1,000 bonus. If somebody refers another person who eventually gets hired, there's a bonus for that. We've done some retention bonuses to target people who have been longer-term state employees that aren't eligible for other kinds of retention. The one that's really had a significant impact is this pickup shift bonus, where we pay $100 if an individual picks up a shift that the superintendent identifies as being hard to fill. That, as we're talking about in response to Representative Ballard's question, I mean, that's let people choose where they want to work overtime to fill kind of essential agency needs. So that's not every shift, but the ones that the superintendent identifies. And then if they split it with somebody else, they get to split the money as well. So then they can work, if somebody wants to take the first 4 hours and then take the second 4 hours. That's paid off quite a bit, just in terms of flexibility. So we are able to track every payroll period, these bonuses, and so we've got on the slide there the totals during fiscal year 2025. So the pickup shift between the full and half shift has been a little close to 800, 900, a little close to $1 million. That's my time. So thanks for, sorry. It's very Pavlovian, the effect that has. But anyway, pickup shifts, you can see that there, the longevity, the amount there, the signing bonus, we've done that 395 times over the last year. Again, we think that's, and for K&I, for Parsons, and for Osawatomie, we've seen some real impact for that in terms of just recruiting and filling vacancies. The other couple of topics that I was asked to talk about were mobile competency and then some of the reimbursement programs that we've got in place for counties and hospitals. So I'll try to go through this relatively quickly. So to put this into context for those of you that don't do this every day or every quarter. So one of our populations that we serve at Larned and Osawatomie are criminal defendants who are ordered to a state hospital to have their competency to stand trial either evaluated or restored. So try to attempt to bring them back into competency so they can complete their criminal process. There's a significant wait time and number of people waiting for that service. So one of the things that we've tried to implement over the last several years is what we call mobile competency. So we take a Larned employee, state hospital employee, and have them work with a county jail to perform that competency service, either evaluation or restoration, in the jail where that defendant is waiting. We have one employee who does that exclusively. That's her job. She travels around the eastern part of the state. And then some people work from the Larned campus but go out on occasion to do this work. We listed on the slide some of the counties where we have a mobile or pilot projects in competency restoration because that's a longer process. It involves group therapy, some individual therapy, some working sessions that have to happen. It doesn't work in every county. There has to be a significant number, 4 or 5 defendants that are waiting for that. So we've been working with Shawnee, Wyandotte, Sedgwick, Douglas, Geary, Leavenworth counties on those pilots. In terms of evaluations, we've worked with more counties. I listed a few on the slide. You can kind of see the numbers of production in terms of, in June of this year, we completed 8 mobile evaluations and completed 2 mobile restorations, and then some that are pending. That was not just there yet. So in terms of what impact that's had on wait time, trying to show you here a couple of charts about the number of male defendants that are on the wait list for service. This is to get either into Larned or Osawatomie and their time that they spend waiting. So in May of 2025, there were 140 male defendants waiting for service, and their average length of time on the wait list for the ones that we admitted that month were 264 days. So our number hasn't varied a lot. We were lower, but it's crept back up into the 140. But the total number of days that somebody's waiting to get into Larned or get into services has dropped off quite a bit as we've been doing more mobile and more throughput and working with one other vendor, which I'll talk about here in just a second. So because we believe that the model of kind of mobile or outpatient competency worked, we entered a contract with Wheat State Healthcare. That's a partnership of all the community mental health centers to use the mental health center staff as kind of the front line for that competency service in counties in their catchment areas. It's been a really important, significant impact on I think the total amount of wait time that people are waiting, and the throughput's gotten quite a bit better as well. In 2024, there were 58 mental health center staff that were trained to conduct evaluations, and 32 were trained to conduct competency restoration. I didn't do the 25 numbers because they're significantly smaller, but this reflects kind of the first full year of the training, and that was almost all mental health centers had somebody trained to do this work. So if a court has a defendant that needs competency evaluation and they're would otherwise order them to Larned and they're going to wait 250 or 300 days, they can call the mental health center, send that order to the mental health center to complete the evaluation while the person's still in jail. And then if that's successful and the evaluation's complete, their criminal process continues, and that's a person that drops off the Larned wait list for both time and the number. If they need restoration, then it starts the regular process, and in many places, the mental health centers are able to do that restoration work as well. The two cup of charts there to show the number of competency stand trial evaluations that mental health centers have done, and you can see the trend of that over time, around 50 a month. And there are mental health centers that are doing restoration, and it's working extremely well for those counties. So we think that's a really important partnership. That's to try to address the wait time by moving people through the process. The other mechanism that you all created with us was Senate Bill 228, which is a reimbursement program that directs KDADs to pay counties for the time defendants wait getting into Larned. So if a county jail is holding an individual that has an order to go to Larned for evaluation or competency evaluation or restoration, we can pay that county $100 a day for every day between when they're ordered by the judge and when they're admitted at Larned. And we've had this in place for a year and a half or so. The statute authorized us to go back to the beginning of fiscal year 2023. So this shows you the total amount that we've paid to counties over the life of this program. Regardless of when the defendant was actually waiting, this is really reflecting more just what counties we've paid over this whole time frame. But it totals about a little over $12.5 million that's gone to counties to help compensate. I don't think it covers the full cost, but it pays for some of the cost that they're spending to have somebody in jail who is ordered to Larned but hasn't gotten in because of the wait time. The other program that will sound similar, but it is different, is in House Bill 2184 from 2023 that created a fund so that we could pay counties, law enforcement, and healthcare providers for time that somebody who's been ordered to Larned or Osawatomie, a state hospital, for treatment on our care and treatment side. So those are involuntarily committed adults in mental health crisis. So if we are making people wait, like Representative Ruiz asked for Osawatomie, you're waiting about 90 hours to get in from when you're approved, screened, ordered by the court, and we've approved you for admission. If you're waiting that time, you're typically in a hospital setting, maybe in the emergency department or waiting room. Somebody's sitting with that person while they're waiting to get admitted to Osawatomie. So we're able to pay the observation cost, part of the observation cost, and transportation for healthcare providers that are in that environment. So these are people who have been ordered to a state hospital. We've approved them for admission. We just don't have a bed for them, so they're waiting someplace else. Could be law enforcement. They're not in custody, but they're in law enforcement, not custody. Law enforcement is holding them, but they're not in custody or in a hospital. So again, we've paid, you've appropriated $5 million a year now twice, 2 fiscal years. And you can see we've spent about $3.4 million between observation costs and transportation. It's pretty messy to look at who we've paid. I tried to do the count. There's a number of different providers, several large hospital systems, not very many law enforcement, because usually there's a partnership between a hospital and either the sheriff or police to do that observation time. But we think that the program is working well. We've had some hangups on the reimbursement side and trying to get invoices paid. We require a little bit of documentation of who the patient is, where they are, when they were ordered, and then we can verify that because we have the orders for admission and when we admit people. We've talked to the Hospital Association a couple of times about ways to improve the timeliness of the program or make it more available to other hospitals. So we're continuing to work on that as we kind of refine the process going forward. Ultimately, we want to get people in faster. We don't want to pay hospitals for work that they don't want to be doing. I think when we get the South Central Regional Hospital open, again, hopefully that'll make a significant impact on wait time, availability of beds, because again, they'll be in a location where there's a significant number of people waiting or ordered Osawatomie, but they could stay closer to home. Lots of things will be different once we get the regional hospital open. But we did want to highlight those couple of programs based on the committee's request.
Thank you, Scott. I'm sure we have questions. We're going to start with Senator Erickson.
Thank you, Scott. Thanks for being here. Just a couple of quick questions on that last slide that you shared, the reimbursement to counties and hospitals. First of all, I'm not familiar with what a state intuition alternative hospital is. Can you help me understand what that is?
I can, I should correct the word because it's state institution alternative. If that sent you in the wrong direction, it's the wrong word. That's my editing mistake. But
Part of it.
the state institution alternative are community hospitals that KDADS is contracted with that have agreed to provide the equivalent care that we do at the state hospitals, the same level of intensity, same kind of patients. And then we pay them a daily rate to do that work. And for the purposes of the mental health centers to do the screening or courts that order people into treatment, it's the same care as though they were admitted at Osawatomie or Larned.
Okay, that makes a little bit more sense. So you say that healthcare providers, law enforcement, or other county entities can be reimbursed. I take it there's probably a cost discrepancy whether they're being held in a healthcare facility versus law enforcement. I don't know what other county entities may be. Would that be the case?
There could be. One of the complexities of this program was figuring out how much to reimburse. So what's the right amount? By definition, this is a service that the hospital can't bill anybody for. So if a person's Medicaid eligible, for example, and they get admitted to an emergency department because they're in a mental health crisis, they get screened for state hospital admission, they meet all the other criteria. As long as the hospital can bill for that service wherever that person is, they bill Medicaid or their insurance provider. These are services that are by definition not billable to anybody else. So it's an observation. So the person's no longer an inpatient or in the ER. They're just being, the hospital's not releasing them until they get to the state hospital. So in talking to hospitals about what's allowable, we've been purposefully, I'm going to say vague, more fluid of what's allowed, because it could be that the hospital has private security. They have a security officer, and so if they have a contract rate for that, we did try to look at that in setting the $60 an hour rate. If they have a contract with the local police department or sheriff's department, we tried to incorporate some of those costs as well, or think about that in the hourly rate. Sometimes it's a nurse or a patient care tech that's doing that work, so there'd be a different hourly rate there. We went through a lot of iterations of that and just kind of settled on, let's set the rate around $60 an hour. We'll pay whoever the first party to the door. So if the hospital submits the claim for a given patient, then we try not to pay the law enforcement for the same patient for the same work. And we haven't really seen any of that, but there could be some cost differences. We did our best to come up with what we thought was a fair rate for something that wasn't otherwise reimbursable.
And my final question, Madam Chair, is I believe, I just want to make sure I heard you correctly, that 10 million, 5 million for 2 years has been appropriated and you've spent 3.4 million, correct? And with the new mental health hospital coming on board, we should see a reduction, not an increase in that, correct?
I think the $5 million appropriation is more than enough given what we've seen and advertising the program at the rates that we're paying today.
Thank you, Madam Chair.
Maybe I didn't talk about transportation. So we do take invoices. So if we pay the federal mileage rate 56 cents a mile door to door round trip. But if they're using a secure transport that's going to cost a lot more than 56 cents a mile, we just pay whatever's on the invoice. So that's the one area where we are trying to cover the cost at the cost the hospital's reporting.
Well, heads up, stamps are going up tomorrow, so everyone go out and buy stamps. They're going up a nickel, so let's not hope our transportation goes up accordingly. So thank you.
Sorry, thank you.
What's a stamp? I have a couple of questions for you while others are thinking about theirs. So I'm glad you mentioned it would be difficult to determine reimbursement rates, because I'm like, how would you determine that? So when we're looking here at reimbursement to counties, can you walk me through how are you notified? How do we get from the person is put into the prison, the jail, and so they're in jail, And then now what to get to this reimbursement? Just walk me through that process.
So for the slide 44, for the,
Uh-huh.
if you're in a hospital, you're, there maybe mobile crisis has interacted with,
I'm sorry, I'm thinking in terms of page 43 and the
oh, the
reimbursement
competency.
to the
Oh,
county.
sure.
So that would be the county jail,
Sure.
right? Okay.
So the person's in custody of the county. There's a criminal charge that the person's standing for trial. The district attorney takes the person to court, and in that initial hearing, the judge decides, I don't think this person's competent to stand trial. We need to have their competency evaluated. Maybe that's a request of the prosecution or the defense. But anyway, the judge orders that person to have their competency evaluated. We modified, you changed the statute a couple of years ago, and we've modified the form that we like judges to use that says if there's a mobile option available, select that first, and if that's not available, then they're ordered to Larned State Hospital, State Security Program. So from the time when that person is ordered to be evaluated until they're either completed the evaluation through a mobile option, mental health center, or one of our team member or one of our staff, we count all of those days from that date of order to the date of either admission or service when it's complete. And then we take that number of days times 100, and that's what we pay the county or the jail. What we did have to do, I think it's prudent, we do ask the counties, either the sheriff or whoever runs the jail, sometimes it's the county treasurer, it varies county to county, that they submit a reimbursement request to us to reflect the defendants that they have that are in that, meet that criteria. So on the form that we had counties fill out, it has who we're paying, their address, some information so we can identify them in the accounting system and pay them. They have to identify the defendant, and if they have a case number, we look at that, and they provide the date that they were ordered and the date that we admitted them. We can then go back and verify through Larned when we received the order, and just to make sure it's the same date, and when we admitted them to make sure it's the same date. And so that's the only verification we really do, is that it's a defendant that actually was on our list, ordered to Larned for either evaluation or restoration.
So it sounds like the judge says they need to be evaluated. They are evaluated. What if they're not found to be suitable for the hospital?
So, well, then they're competent to stand trial, and they stay in the criminal
So you don't have
process.
to reimburse anything, right?
We reimburse until we've made a determination. If they've been ordered for evaluation, we reimburse until they've been evaluated, regardless of what the evaluation says.
Okay.
If they're competent, we still pay for that time. If they're not competent, we pay for that time, and then we kind of start looking for them as being a restoration, somebody who's going to get
I
ordered
don't
to restoration.
understand why, it seems almost like it'd be the flip. It seems like jail would have to, or somebody would, the county would have to reimburse for the evaluation. Am I missing something?
Well, the statute says that the state security program is responsible for producing that evaluation once it's ordered by a judge.
Okay, so,
There are some courts that pay for a private evaluator, or, and we haven't gotten into the money side of who should pay for the evaluation, because we just want to get the evaluations done in a timely way. So we're paying for the wait time.
so you're paying for the wait time even if the person is found to be competent?
Yes.
Wow. All right, additional questions, committee? Oh, you've got them. Representative Ruiz.
Thank you, Madam Chair. This is more of a plug for a summit that's coming up that involves a lot of the work that's done with the court system in behavioral health. All of us, all the legislators received an email. You would have gotten one in June, and then one most recently, I think around July 11th. The summit is the Kansas Mental Health Summit, August 26, 27. And the purpose is really to support a national initiative to improve court and community response to mental health. And so want to go more into the weeds with this, it'll be covered in the conference. So find your email. It's in Hayes, yeah. It'll at Fort Hays University. So thank you for
Thank you
the
for
plug.
mentioning that, Representative Reese. That's, I've already responded that I have a conflict. I'll be gone all that week, but I hope that others can attend. Representative Bryce.
Thank you, Madam Chair. Just a quick question. I don't know if you had mentioned telemedicine. I was wondering about telemedicine, if it's been considered use for the competency evaluations instead of sending staff around the state. The other is telemedicine used in the initial evaluation for admission to a hospital, or how exactly does that process work? Do you rely on emergency physicians on the ground, or emergency or staff at the hospital, or do you have telemedicine capabilities for that? Thank you.
Great questions. So we do, if a defendant will cooperate and we can complete the evaluation over video, we do that. So that's part of what we consider mobile competency, that it's done in the jail setting. Outpatient is probably a better term, but so we do that. There are a number of defendants that either won't cooperate in that setting. There are not a lot of jails that don't have the capability of connecting that, but where it's possible, we do mobile or do video-based competency evaluations. Some are more complicated, some defendants are more violent, just doesn't work, but where we can, it does work. On the screening side for state hospital admission, so if you're in mental health crisis, the community mental health centers around the state are statutorily required, and by contract, the agent who does the assessment or the evaluation for admission to state hospitals. So mental health centers can do that. They can do it mobily if that's possible. Some contract with Health Source that provides the after-hours support for a lot of mental health centers, and they can do things mobily as well. And doing that, it's a screening form that they go through with some questions. There are some medical components to it, but all things that a qualified mental health professional can complete. So where it's possible, they do it through telemedicine or video to complete the screen. We don't do that. That's mental health centers and part of their responsibility.
Representative Bueller.
Thank you, Madam Chair, and thank you for being here, Scott. So the question I'm going to ask, I think, is kind of framed in February in appropriations when we were saying no more contract nursing, and so several of my colleagues were just saying that drop the hammer on it. So, and I think we're going to have separate discussion in a later interim committee on that. But what I wanted to know, or at least do you have knowledge of, is the state of Oklahoma, Missouri, Nebraska, our neighboring states, are they in the same boat with similar institutions? Do you do any benchmarking with them? And I know geography makes a big difference in everything else, but I'm just curious, because I go back to that Appropriations Committee meeting, and it was like, how in the heck are we going to solve this problem? Which to some degree requires looking at out-of-box solutions. So I'm just curious as to what our neighbors might have, or if there are best practices.
We haven't done that specifically. We do participate with some national organizations, and that might be a good place for me to ping them and see what they've done. I can't remember that they've done a study about staffing levels or contract labor, but we can do that before you all meet in August or September, or whatever day you wanted to do. Well, we'll start on it now, so we'll be ready for whatever day you choose. But that would be a good thing to know, as just kind of from reading the what our national organization sends out and just other media. I don't think we're in a unique situation. I don't, scale-wise, I'm not sure. Talking to some of the contract staffing vendors, they have told us that it's a similar kinds of rates, similar kind of contract requirements we have in Kansas. So I think we're, in terms of what we've got out there in the environment to bid on, is competitive, but in terms of scale, we need to do more investigation.
Senator Peck.
Thank you, Madam Chairman. I'm looking at the page, or whatever you call it, 39 and 27. I just picked off SWAT. I mean, I could probably pick any of them as relates to the bonus payments. Osawatomie, I'm looking only at longevity, signing, and retention, which, by the way, longevity means they've been there quite a while, because if I remember correctly, we eliminated the longevity bonuses for new employees many years ago, 10 years, 15 years ago or so. So these 90 longevity would be individuals who've been at Osawatomie for quite a period of time, right?
Yes, I'm trying to remember if we put the $40 a year for every year up to 25 years. Unclassified staff for, I'm sorry, that's what the current longevity is. For if you're 10 years or over, it's $400, more than 10 years.
I was thinking that we had eliminated longevity bonuses around 2008, something like that.
They still exist for classified employees, but not for employees in the unclassified service. So there's no.
Classified can still receive longevity?
Yes.
Okay. But the question, looking at Osawatomie, in round numbers, 540 positions, 750 bonuses when you add 90, 82, 578. And I understand an employee could receive a signing bonus after 90 days and then a retention bonus. So help me understand, 500. So are we, my point is, or my question ultimately is, are we having people take these bonuses and then they quit? They hang around long enough to get the bonuses, then they quit. Because we're paying significantly larger number of bonuses than we have positions.
In talking to the superintendents, I don't think they've seen a significant number of people that stay long enough to just get the bonus and leave. Although if that happens anywhere, it's probably more on the sign-on bonuses, but you do have to meet those thresholds of be an employee for at least 90 days. But then after that, we have turnover. We picked 90 days because looking at our data, that was one of the critical drop-off points, that if we can keep somebody past their 90th day, 100th day of employment, they're going to stay a longer term. So that was intentional. The total numbers, again, employees could get multiple, I don't know if it'd be all of these. Longevity would be unlikely, but you could stack these bonuses for a given employee. So the total number, just the number of bonuses that paid, is going to exceed the number of employees just because they are eligible for more than one of these.
That's a significant difference between 540 positions and 750 bonuses. So I'm just asking if there's some explanation for the difference in the numbers.
In that you can stack them. The retention bonus was also two-phased, so that any employee that was eligible would get 2 payments, so that's counted in there. But it's mostly because we could stack these up for the total of up to, it couldn't exceed $10,000 for a given employee. That was the other limit. So if there were any other, the pickup shift bonus, there was no limit on how many times you could take that until you hit that dollar threshold.
That's the reason I didn't even look at the pickup bonuses, so just the I'm still employed bonus. Okay, thank you.
Yeah.
Thank you, Madam Chairman.
Representative Carpenter.
Thank you, Madam Chair. Scott, so this is kind of some questions that'll probably be pertinent to our interim committee that we have on these state hospitals, but I'm just adding quick numbers here. I hope my calculator works fine so I don't make any you-know-what of myself, but OSHA's numbers, that's $152,000 a year per person. So that's $73 an hour on average. Do we have a breakdown of that? I mean, obviously that's just employees, but is that nurses? Is it MHIDTs? You know what I'm saying? And the same thing with Learned. If you divide that out, what we paid, it's $193,000 a year, and it averages about $93 a year. So I'd be curious, is someone making $1 million and the other guy's making $50? And you see what I'm saying? These are just raw numbers.
I think so. So we, as part of our rate setting process for Medicaid, we do annual cost reporting that follows our Medicaid state plan for what's included as costs. And then we convert or roll that into a daily rate. So our daily rate for osawatomie is around $1,100 a day, and Larned is somewhere around 900. I don't remember the exact amount. But that reflects all of our costs. So all the medical staff, the nursing related to those certified programs, maintaining the buildings, feeding people, providing medical care. So that's all in that daily rate. So the cost of care, we could show you what goes into that calculation of that daily rate, which I think would get to some of your question.
Maybe I'm not making myself clear. This is just contract nursing. This is just contract labor.
Oh, okay, I'm sorry.
Sorry, I didn't make myself very clear. I'm just dividing out contract labor. And so it comes out at $152,000 a year at OSH for each contract.
Contract person.
And $193,000 at Larned, $93 an hour.
Yes. We work from state contracts for nursing. For Larned, we've capped the contractors we work with at only those that charge $90 an hour or less for an RN. So that would be, so $93 would be close to that. There'll be some overtime that gets in there and some that are a little bit more expensive. Osawatomie's done something fairly similar. Their cap's a little bit higher just with the contractors they work with. But we've tried to limit, so our contract rates, we can provide that back to the special committee too of what's available on that state contract, because there's about, I forget the last number because they just redid it, but 50 to 70 vendors that are on that contract with prices that range from, I don't think there's anybody much below 90, and then they go up quite a bit from there for an RN equivalent position.
And so are we contracting for doctors too?
Yes.
Okay, so we're.
For coverage or.
It'd be helpful to have a breakdown of who we're contracting for, and because obviously that's pretty good money. I might think about going to work there myself for $193,000.
Representative, if I don't know that you're a doctor, but I can find you. I can find you a job if that's something you're interested in. In Larned in particular.
I could see you salivating, Scott. Hired right now, yes.
I don't go very far without asking people if they want to come work for us.
All right, Senator Erickson.
But I can break that down. Thank you sorry for being slow to pick up.
Thank you, Madam Chair. Just a real quick follow-up on Senator Gossage's earlier question. I'm just curious, what percent of inmates or those being held in jail are waiting for a competency evaluation? Do we know that?
I don't know how I would estimate that, Senator. Maybe some of our friends from law enforcement could talk about that, but I don't have a sense of. One of the issues we've had with the contract with Wheat State and in trying to assess the need is not all of the orders come to Larned directly, so they can, but. So I don't have that knowledge at all, Senator.
Maybe going back to Senator Gossage's question, I'm sitting here and thinking if I'm wanting to minimize my cost, and it doesn't matter if I referred or I ordered an evaluation, you're going to be paying for it. I'm going to be ordering every single person to get an evaluation to cover my costs of I mean, maybe I'm just been around the legislature too long and looking for ways to save money, but
I don't think
so I'm just wondering what percent. That would be my question. Thank you, Madam Chair.
We are at time, but I've got a senator over here that's turning red in the face that he wants to answer so quickly. Please go ahead, Senator Owens.
Thank you, Madam Chair. Yeah, this was a topic we studied extensively session before last in corrections. And first of all, it's important to understand that the judges are the one that order competency, and they have no dog in the fight over the funding for the jail. It's not their bailiwick or their responsibility. However, what we were seeing were defendants that were sitting in jail for 6, even 9 months waiting on a competency hearing. And that is not due process. And so when that does happen, that does put our counties in one heck of a bind because they are paying $80, $90, $100 a day to house that inmate while they're waiting on the state to act, because this is a state responsibility. And so as a bit of a motivator, if you will, it was, hey, if it is not the county's fault that they are sitting there, but it is the state's fault that they are sitting there, then the state should have some ownership of the cost of that defendant sitting there. And that's actually what's led to a lot of this mobile competency coming on board. And I would argue, and this would be a great conversation to have with the judicial branch, I'm willing to bet, as we've seen those come on board, those numbers are coming down. And that motivation is actually working to get people through the judicial process faster. Because if they are, adjudicated or do receive restoration services, their case proceeds, probation, time in prison, whatever that ends up, it moves that process along. But yes, there were hundreds of inmates sitting. You probably have more than 100 sitting in Sedgwick County alone that are waiting on competency evaluations right now. So just a little bit of context from the other side of that, because we did really dig deep into this and worked with law enforcement in the counties to try to find a way to really honestly offset some of their costs because of how long the delay is on the state performing the service.
Thank you, Senator Owens. Very worth it. Committee, I will not be here tomorrow. Representative Carpenter, of course, will be, as vice chair, taking over. I will be at the American Legislative Exchange Council meeting where I serve as vice chair of the Health Committee and chair of the Medicaid Committee. I will also serve on the National Council of State Legislators, serve on that health committee. So what I intend to do, I'm going to be asking questions about how do they handle their how do other states handle their competency tests, and also ask for ideas on state hospital staffing and what other states are doing, the question that was asked earlier. 2 weeks ago, I had the opportunity to sit down for a couple of hours with Peter Nelson. You may know that he's the director for the ACA, and talk to him about some of the concerns that we've seen in the marketplace and some things that are improved. Don't have a meeting yet, but there was one that was set up a month or so ago that I wasn't able to attend, but I hope to attend soon, and it's with Dr. Ozen and Secretary Kennedy Jr. about some of the things that we are seeing. And so again, I will reach out to the department. If you have anything you would like for me to bring up on behalf of our state, I would be happy to do that. In committee, we are adjourned.